Dear doctors, I am Dr. Vidhya, your OB&G faculty at DocTutorials. I welcome you all to this FMGE QRP Quick Revision Program 2022. And in this quick revision program, we'll be discussing the recent FMGE papers, the last 3 to 4 FMGE papers, because more number of repeats are coming every year. It's important to know the recent questions, and also we will be discussing the points that are likely to be asked from the previous questions. If not the direct questions, some questions can be the modification of previous year questions, which we will be discussing now. Okay. So, let us begin with the June 2022 paper, which is the most recent paper. So, question number 1 is here. Which among the following is the most common cause of postmenopausal bleeding? So, which among the following is the most common cause for postmenopausal bleeding? And here are some conditions. Option A is atrophy. Option B is endometrial cancer. Option C is cervical cancer. And option D is endometrial polyp. Okay, so let us first see the definition for postmenopausal bleeding. What is the definition for postmenopausal bleeding? The definition for postmenopausal bleeding is bleeding from the genital tract, after 1 year of cessation of bleeding, after 1 year of amenorrhea. Okay, bleeding from the genital tract after 1 year of amenorrhea is postmenopausal bleeding. So, this is the cutoff. 1 year is the cutoff. But as per the guidelines, any bleeding after 6 months of amenorrhea, any bleeding after 6 months of amenorrhea should be evaluated in the same way as we evaluate postmenopausal bleeding. Okay, so this should also be evaluated. Okay, so according to the definition, the cutoff is 1 year of amenorrhea. Okay, so what are the causes of postmenopausal bleeding? The causes of postmenopausal bleeding are: number 1, endometrial atrophy. What is endometrial atrophy? Because of estrogen deficiency, the endometrium shrinks too much and the underlying myometrial vessels get exposed. So, endometrial atrophy is one important cause of postmenopausal bleeding, and in fact, endometrial atrophy is the most common cause of postmenopausal bleeding. Okay, so the most common cause of postmenopausal bleeding is endometrial atrophy. The second most common cause is endometrial polyp. Okay, endometrial polyp. Then comes endometrial hyperplasia. Endometrial hyperplasia, and you all know endometrial hyperplasia is a pre-malignant lesion, right? So, which malignancy arises from endometrial hyperplasia? Endometrial cancer. Okay, endometrial cancer. And last but not the least, hormone replacement therapy. Okay, hormone replacement therapy. So, what is the most common indication for hormone replacement therapy? Hot flushes. Okay, so whenever we give estrogen and progesterone for hot flushes, we can expect the woman to bleed, and that's bleeding due to hormone replacement therapy. Okay, so the 5 causes for postmenopausal bleeding are endometrial atrophy, endometrial polyp, endometrial hyperplasia, endometrial cancer, and hormone replacement therapy. Of course, apart from these endometrial causes, we can also expect bleeding from the cervix, the vagina, the vulva, and it can be malignancies involving any of these structures, any of these sites, malignancies or infections or erosions. Okay, so cervical cancer, vulval cancer, vaginal cancer, cervical erosions or infection, all these are rare causes of postmenopausal bleeding. The most common causes being endometrial causes, and those endometrial causes are the 5 that I mentioned. Okay, endometrial atrophy, polyp, hyperplasia, cancer, and hormone replacement therapy. Now, what are the other questions that can be asked from this? What percentage of postmenopausal bleeding are actually due to endometrial atrophy? Remember, 60% of the postmenopausal bleeding are due to endometrial atrophy. Okay, 60% of them are due to endometrial atrophy. Remaining together make 40%, roughly 40%. Okay, so polyp, HRT, hyperplasia, and malignancy together make the remaining 40%. So, 60% of them are due to endometrial atrophy. So, next question is, what is the investigation of choice? What is the investigation of choice in the evaluation of postmenopausal bleeding? Please remember, we will, once the patient comes with postmenopausal bleeding, we will definitely examine the patient. Okay, so we'll do a per speculum examination for her. Simultaneously, we'll also see the cervix. Okay, so we'll also take a pap smear. So you all know the guideline says pap smear has to be taken till the age of 70 years, provided the last 3 smears, the last 10 years smears are normal, you will stop screening her at the age of 70. So if supposing the patient attains menopause by the age of say 50 or 55, and the patient comes with postmenopausal bleeding at the age of 58, still she is a candidate for pap smear. So simultaneously, when you do a per speculum per vaginal examination, you will also take a pap smear if she is due for that. Okay. And then for endometrium per se, what investigation will you do? That is investigation of choice. So that investigation is, yes, what is it? Yes, correct. That investigation is transvaginal ultrasound. You all understand? Okay, the investigation is transvaginal ultrasound. Okay, very important MCQ, transvaginal ultrasound. Okay, after you perform a transvaginal ultrasound, you will get to know the endometrial thickness. Okay, so what is the thickness here? The normal endometrial thickness for a postmenopausal lady, can anybody tell? Yes, the endometrial thickness for a postmenopausal lady, what is the cutoff? Yes, the cutoff is 4 millimeter. Okay, the cutoff is 4 millimeter. Okay, so if the endometrial thickness measures less than or equal to 4 millimeter, it is due to what? It is due to what? Atrophy or hyperplasia? It is due to atrophy. It is due to atrophy. Okay, if it is more than 4 millimeter, if it is more than 4 millimeter, then it is probably due to other cause like hyperplasia or polyp or malignancy, which requires further evaluation, and then you will do the next level of investigation. And what is that? Yes, if the endometrial thickness is more than 4 mm, what will you do next? Yes, okay, I'll give you options. Options are option A, Pippel's endometrial biopsy, option B, hysteroscopy guided endometrial biopsy, option C is fractional curettage. Out of these 3, which one will you pick? Give me your answers, all of you. If the my question is, if the endometrial thickness is more than 4 millimeter, if the endometrium looks thick in ultrasound, okay, what is the investigation of choice there for a thick endometrium? Is it Pippel's endometrial biopsy or hysteroscopy guided endometrial biopsy or a fractional curettage? See, the correct answer here is Pippel's endometrial biopsy. Okay, the correct answer is Pippel's endometrial biopsy. Okay, so when will you do a hysteroscopy guided biopsy? Hysteroscopy guided biopsy will be done if there is a focal lesion or a focal thickening. Okay, so if it is a diffuse thickening, then the investigation of choice is Pippel's endometrial biopsy. If there is a focal thickening, okay, if there is a focal thickening or a focal mass, then you will go for hysteroscopy guided biopsy. I hope you all are clear with it. Hysteroscopy guided biopsy. Okay, so a quick recap on whatever we've learned about postmenopausal bleeding. The definition of postmenopausal bleeding is bleeding from the genital tract after 1 year of amenorrhea. Okay, the causes, which is the most common cause? Yes, give me your answers. Which is the most common cause? Yes, correct. Endometrial atrophy is the most common cause. Okay, fine. What is the investigation of choice to evaluate postmenopausal bleeding? The investigation of choice to evaluate postmenopausal bleeding is transvaginal ultrasound. Transvaginal ultrasound. Okay. If transvaginal ultrasound shows a thick endometrium, what will you do? If it shows a thin endometrium, you will only reassure the patient. Okay. If the endometrium is thin, all that is required is reassurance. If the endometrium is thick, then the next investigation will be, yes, Pippel's endometrial biopsy. Correct. Pippel's endometrial biopsy. Okay. So these are the probable questions that can be asked from postmenopausal bleeding. Okay. We'll move on to the next here. See the next image. Identify this image. So it is damn easy, right? Yes. This is very, very easy. But what you need to know is the relevant points related to the image. Okay. The differential diagnosis that can be thought of. Okay. So you very well, you can see that the placenta is here. Placenta is occupying the lower segment of the uterus. So this is the placenta. This is the placenta. And this is the umbilical cord. Okay. The umbilical cord. And This is the cervix. This is the cervix and this is the internal os of the cervix. I am marking it with blue. This is the internal os of the cervix and this is the external os of the cervix. Yes. So, this is placenta previa. This is placenta previa. Okay, fine. We do have other differential diagnosis here. So, from the image, it's very clear that this is placenta previa. So, what is abruptio placenta? Abruptio placenta is premature separation. Abruptio placenta is premature separation of a normally situated placenta. Okay, abruptio placenta is premature separation of a normally situated placenta. Okay, I'll show you one other image now, so you have to identify that too. Okay, so let us see the next image. See this image, all of you. See this image. There's a placenta here. So, this is the placenta. This is the placenta. Okay, and this is the uterine wall. Here is the uterine wall. In between the placenta and the uterine wall, there is some amount of hemorrhage here, blood collection. So, I call this as retroplacental clot behind the placenta. Retroplacental means a clot behind the placenta, in between the placenta and the uterine wall. Okay, retroplacental clot. Okay, so what condition is this? Retroplacental clot is seen in which condition, which obstetric emergency? Tell me. Yes, retroplacental clot is a pathognomonic feature of. Give your answer. Yes, retroplacental clot is a pathognomonic feature of abruptio placenta. Okay, retroplacental clot is a pathognomonic feature of abruptio placenta. Abruptio placenta. You all understand? Because of the premature separation of the placenta, blood collects between the placenta and the clot. Okay. Now, see this one, all of you. See this one. See here, you can see that the placenta is attached only to the uterine wall and does not enter into the myometrium. Whereas, in the next image, you can see, compare this to the previous one. Here, you can see that the placenta, the chorionic tissue is little invading the myometrium. In this, you can see that the placenta has invaded the full thickness of the myometrium. It has gone up to the serosa, but it hasn't involved the serosa. And here in the last image, you can see that the placenta has completely perforated the uterus and it has crossed the serosa and it has protruded out. Yes. What are these conditions called as? They are called as accreta, increta and percreta. Placenta accreta, increta and percreta. Okay. So, accreta is placenta invading the myometrium. Placenta just invading the myometrium. What is increta? Increta is where placenta involves the full thickness of the myometrium. Placenta invades the full thickness of the myometrium, and percreta is a condition where placenta invades the serosa. Percreta is where placenta invades the serosa. You all understand the difference, no? Yes? The difference between accreta, increta and percreta? Okay. Fine. So, this is accreta, increta and percreta. Okay. So, you know what is abruption now, you know what is previa, you know what is accreta. The last one is vasa previa. Vasa previa. Guys, you tell me what is vasa previa? What is vasa previa? Okay, you tell me what is the main difference between vasa previa and the other three conditions. What is the main difference between vasa previa and the other three conditions? Here. Okay, who bleeds in vasa previa? Is it the maternal bleed or the fetal bleed? Of course, all these are conditions which can present with hemorrhage. Okay, the common point between all the four conditions is that all these can lead to obstetric hemorrhage. Obstetric hemorrhage. Okay, so placental abruption, placenta previa and vasa previa are usually causes for antepartum hemorrhage. That means during pregnancy. And accreta, increta, percreta is usually a cause of postpartum hemorrhage after delivery. Okay, so the main difference between vasa previa and the other three condition is that in vasa previa, the blood is of fetal origin. Okay. So, who bleeds? It is the fetus who bleeds. Okay. So, in vasa previa, the blood is of fetal origin. Blood is of fetal origin. Okay. So, here you can see that the placenta is here. The placenta is here. Okay. And there are vessels running through the umbilical cord to the baby, and these vessels are lying directly over the cervix. Okay, so when you do a pervaginal examination, you're likely to injure the vessels, the umbilical vessels, whose vessels are umbilical vessels, they are fetal vessels. So obviously when they get injured, it is the fetus which is going to bleed. Okay, so this is vasa previa. So since it is an image based question, I thought I'll show you all the images related to this question. So this is placenta previa, abruptio placenta, accreta and creta porcreta, and here what you're seeing is vasa previa. So these images can be expected in the next exam. Now apart from these images, I also want you to know certain points about previa and abruption, because we had this question in the last INI-CET exam. Okay, so November 2022 INI-CET exam. So it's worth knowing the difference between abruption and placenta previa. Okay, now in placenta previa, the bleeding is usually painless. Okay, placenta previa is a painless bleed, whereas abruptio placenta is a painful bleed, and in fact this is the most important difference. So here it is painless and here it is painful bleed. Okay, so which condition is associated with hypertension? Tell me, previa or abruption? Which one is associated with hypertension? Yes, hypertension. It is right, abruptio placenta. Okay, placenta previa is a problem with the location of the placenta. Okay, in placenta previa there is a problem with the location of the placenta, whereas it is abruption which is associated with hypertension. Okay, and also remember in abruptio placenta there are three varieties: concealed, revealed and mixed. Revealed is where the blood readily comes out. Concealed is where the blood collects behind the placenta and forms a huge retroplacental clot. So the patient will hardly present with bleeding pervaginum in concealed type of abruption, but other features of abruption will be there, like big uterus, tense tender uterus and abnormal fetal heart rate. All these will be there in concealed type. Okay, mixed variety is where you have bleeding outside as well as inside, so that's mixed. So of course the most common type is a revealed type. Okay, this is the most common type of abruptio placenta, whereas there in placenta previa the bleeding is always revealed. Okay, so where do you see dark altered blood and where do you see bright red blood? Tell me. See, whenever the blood collects inside, it becomes a clot and with time it changes color. So that is where you see dark altered blood. Okay, which condition is that? Which condition is that? Yes? Yeah. In abruptio placenta, the blood is dark in color, and in placenta previa, the blood is bright red in color. Okay. So whenever there is blood collection inside, okay, what you see outside through the vagina will be only a part of what is actually happening inside. In that case, anemia will be disproportionate to the amount of blood loss in concealed type of abruption. You understand my point? In concealed type of abruption, the anemia, bleeding will be very less, very scanty. In fact, sometimes the woman will present with no bleeding, only with pain and tense tender uterus, but she will be grossly anemic. So why is she anemic? Because the blood is collecting inside. Okay, so anemia will be out of proportion in concealed, and anemia will be proportionate to the blood loss in placenta previa because it is always revealed type, no? Yes. So here the height of the uterus will be the same because there is no blood collection inside. Here the uterus will be enlarged because most of the time there is a retroplacental clot. Okay, so here the uterus will be soft and relaxed. Here the uterus will be tense and tender uterus. Okay, so this again is a very, very important diagnostic point. Tense and tender uterus is seen in abruptio placenta. Okay, so here you don't see, where do you see malpresentations? Malpresentations are seen whenever there is a mechanical obstruction for the baby to rotate. Okay, see, placenta previa is a chronic condition, whereas abruptio placenta is an acute condition. It is an acute emergency. Okay, so usually malpresentations are seen in conditions, chronic conditions where there is a hindrance for the baby to move, hindrance for the baby to take its comfortable position. So obviously when there is placenta in the lower uterine segment, the baby will not be able to accommodate its head in the lower uterine segment because where the head has to sit, now it's the placenta which is sitting. You understand? So malpresentations are common in previa, whereas not in abruption. Okay, and which is life-threatening? Tell me, previa or abruption? Which is more dangerous? Which is acute? Which is more life-threatening? Where do you more commonly see intrauterine fetal death? Previa or abruption? Where do you see more commonly intrauterine fetal death? Yes, IUD is a feature of Correct. Abruptio placenta. Okay. IUD is a feature of abruptio placenta and not previa. Okay. And again tell me, where do you see DIC, disseminated intravascular coagulation? In abruption or previa? DIC. Yes. Again, DIC is a feature of abruptio placenta, because I already told you that abruption is associated with hypertension and preeclampsia. Okay. So, DIC is a feature of abruptio placenta, and here the fetal parts will be difficult to palpate. It will be difficult to palpate the fetal parts because there is clot inside. Okay, so these are the differences between previa and abruption. And also remember, previa is called as warning hemorrhage. Previa is called as warning hemorrhage, whereas abruption is also called as accidental hemorrhage. Warning hemorrhage, accidental hemorrhage. Okay, so this is the very recent INI-CET question. We had one question from previa. We also had one question from abruption. Okay, so it's very, very important to know this. Okay, fine. We'll move on to the next question. So here is the next question. Again, it's an image-based question. Identify the image. Okay, so the image which was there in the exam is more likely to be something like what I have shown here. Okay, but there are few more important MCQs that you have to know apart from identifying the condition. Okay, now it's very easy to identify the condition because it is labeled as uterus here and it is labeled as bladder here. So you can see that so obviously this is the vagina and this is the bladder. So there is a connection between the bladder and the vagina. So what is it called as? This is called as vesico-vaginal fistula. This is called as vesico-vaginal fistula. Okay. But there is something more to learn about vesico-vaginal fistula, which can be expected to be asked in the next FMGE exam. Okay, so fine. What are the different types of genital fistula? Okay, now see this image and you tell me. Okay, now let's say this is the uterus. This is the uterus. This is cervix and this is vagina. This is vagina. Okay, I am marking this as 1. Okay, there is a connection between two structures which is marked in purple. Okay, I am marking it with number 1. So tell me, what is number 1? Yes, it's a connection between the bladder and the vagina. So what is it? Yes, this is vesico-vaginal fistula. This is vesico-vaginal fistula. So what is number 2 here? Number 2, yes, it's a connection between the urethra and the vagina. Urethra and the vagina. So what is it? This is urethro-vaginal fistula, and this is ureter. Okay, so this one is ureter. Okay, so here there is a connection between the ureter and the vagina. Ureter and the vagina. What is it? This is uretro-vaginal fistula. Uretro-vaginal fistula. Okay. Apart from these, there is one other type. Here, there will be a connection between the uterus and the bladder. Okay, uterus and the bladder. So, this is called as vesico-uterine fistula. This is called as vesico-uterine fistula. Okay, so in this image, I have shown 4 fistulas: vesico-vaginal, urethro-vaginal, uretro-vaginal, and vesico-uterine. Okay, now what are the other important MCQs apart from identifying the type of fistula with a given image? We'll have to know something more. Okay, now which is the most common out of these? I just showed you 4 types of fistula, right? Out of these, which is the most common urinary fistula? What is your answer? What is your answer? Which is the most common urinary fistula? Yes, the most common urinary fistula is vesico-vaginal fistula. Okay, the most common is vesico-vaginal fistula. Okay, so next question is about the cause. Which is the most common cause of vesico-vaginal fistula in our country, in India? What's your answer? Yes, in our country, the most common cause of vesico-vaginal fistula is it a gynec cause or is it obstetric cause? Yes, it is obstetric cause. Okay, and the most common cause is obstructed labor. Obstructed labor. Okay, the most common cause of vesico-vaginal fistula in India is obstructed labor. Okay, Next question is this. What is the most common cause of vesicovaginal fistula in the developed world? In the developed world, what is it more often due to? Yes, in the developed world, it is more of gynec cause. It is more of iatrogenic cause. It is due to surgeries. Okay, in the developed world, it is more often due to surgeries. Okay, so pelvic surgeries that are performed, like say hysterectomy or any other pelvic surgery, and that is the most common cause of vesicovaginal fistula in the developed world. Okay, what is the most common cause of ureterovaginal fistula? This fistula. What is the most common cause of ureterovaginal fistula? Yes, here the answer is cesarean section. The most common cause of ureterovaginal fistula is cesarean section. I don't know how many of you had assisted cesarean sections. So when we perform cesarean, what do? We separate the UV fold of peritoneum and we push the bladder down, and then we make an incision on the lower segment of the uterus. Correct? Sometimes when there is too much of distension of the lower uterine segment, when the patient has been in labor for quite some time and the lower segment is stretched a lot, you make an incision at the lower segment of the uterus. What will happen? Because the lower segment of the uterus is very thin, it will be difficult to identify the lower segment of the uterus and to differentiate it from the vagina, which is lower down. And in that case, if the incision extends a little bit down when you extract the baby, when it extends a little bit down, it is likely to extend into the vagina. Okay, this is usually a complication of prolonged labor. Okay, so most common cause of okay. So next is most common cause of ureterovaginal fistula. Ureterovaginal fistula, this is usually seen after hysterectomy. Okay, ureterovaginal fistula is a complication of hysterectomy. Okay, so these are the MCQs here. Most common cause of vesicovaginal fistula is obstructed labor in India. Most common cause of ureterovaginal fistula is hysterectomy, and vesicouterine fistula is cesarean section. Okay, fine. So again, a few more MCQs I'll tell you. There is something called 3-swab test. 3-swab test to differentiate these types of fistula. Okay, so, there is always a need to differentiate ureterovaginal, vesicovaginal and ureterovaginal fistula. Okay, so forget the vesicouterine fistula. There is always a need to differentiate these three fistulas, 1, 2 and 3. So how do we differentiate? There is a clinical test called 3-swab test. Okay, so in this 3-swab test, what we do is we instill the a dye called methylene blue. We instill a dye called methylene blue inside the bladder. Okay, and we place 3 cotton swabs, one on the upper vagina, one in the middle vagina and one in the lower vagina. Okay, let's say this is the cotton swab that I am placing. Okay, let's say this is the cotton swab that I am placing. I am placing one here and one here, and simultaneously what have I done? I have put some dye inside the bladder. Okay, so here I have put some dye, methylene blue dye. Okay, now what will happen? This methylene blue dye is likely to pass through the fistula and soak the cotton that is placed in the vagina. Okay, so where all will you have dye staining and where all will you not have dye staining? Okay, listen, if there is a ureterovaginal fistula, what will happen? In this case, ureterovaginal fistula, because there is no sphincter here, continuously there will be dribbling of urine from the ureter into the vagina, because of which the uppermost swab will be soaked only with urine but not with dye. Okay, so if the uppermost swab is soaked only with urine and not with dye, it is ureterovaginal fistula. Whereas if the middle swab is soaked with the dye and urine, it is vesicovaginal fistula. Okay, if the upper and the middle are dry and if the lower swab is soaked with dye, it is ureterovaginal fistula. Okay, so that's how it is. Hope you all understand. If the upper swab is soaked with urine and not with dye, it is ureterovaginal fistula. If the middle swab is soaked with dye, it is vesicovaginal vaginal fistula, and if the lower one is soaked with dye, it is uretherovaginal fistula. Okay, I think I'm clear about it. Okay, so this is about fistula. These are the questions that you can expect in the next FMGE exam. Okay, moving on, we have the next question here. A couple came to the clinic with complaints of infertility. On examination, her husband had gynecomastia and tall stature. What is the possible diagnosis? So here, this is a very easy and a straightforward question. First of all, the answer is Klinefelter syndrome, which is very easy, which doesn't require any further explanation. But let us see something about Turner's, Swires and testicular feminization syndrome and also how to exclude these options. Okay. Now coming to Turner's. All of you will tell me, in Turner's, the gender identity is girl or a boy? What is the gender identity in Turner's? Will the person be identified as a girl or a boy? Yeah, the gender identity in Turner's is girl. The gender identity in Turner's is girl. What is the gender identity in Swires? Again, the gender identity in Swires is girl. Okay, and testicular feminization also. You all understand my point. What is the gender identity in TFS, testicular feminization syndrome, which is otherwise called as androgen insensitivity syndrome? See, in all the three, other than Klinefelter's, in the other three, the gender identity is girl. Okay, that means identified as a girl and raised as a girl. Okay, in Klinefelter, the gender identity is usually boy. Okay, so this person in Klinefelter will be identified as a boy and will be reared as a boy. Okay, this is the first important difference. So here it is being mentioned that the husband has gynecomastia. So definitely the gender identity is the patient has been identified as a male, which itself is in favor of Klinefelter. Secondly, in Turner's, Swires and testicular feminization syndrome. In Turner's, what is the karyotype? In fact, we recently had one question in the last INI-CET exam. We had question on Turner's, but that again was a very simple question. What's the karyotype in Turner's? The karyotype in Turner's is 45X. Okay, and the gonads are streak gonads. Okay. Swires, what is Swires? Swires, what is the karyotype in Swires? All of you tell me, what is the karyotype in Swires? Yes? Is it 46XX or 46XY or any other karyotype? The karyotype in Swires syndrome is 46XY. Yes? Okay? The karyotype in Swires is 46XY. Now, what's the problem in Swires? Why is it a disorder of sex differentiation? In Swires, the SRY gene is mutant. In Swires, the SRY gene is mutant. SRY gene is mutant. So what happens? This gene is a very essential gene for the normal development of testes. Okay, the SRY, where is SRY gene present? Tell me all of you. Where is SRY gene present? Come on, give your answers. Give your answers in the chat box. SRY gene is present in the Y chromosome, long or short arm? Where is it present? SRY gene is present in the short arm of Y. SRY gene is present in the short arm of Y. And you all know SRY gene is important for the development of testes. Okay. So here, because this SRY gene is mutant, the gonad will be a streak gonad. Here again, the gonad will be a streak gonad. So I call it a dysgenetic testes. Dysgenetic gonad or a dysgenetic testes, which is at risk for malignancy. Okay. Any non-functioning gonad, any undescended gonad is at risk for malignancy. Here again, the gonad is a non-functioning gonad which is at risk for malignancy. Okay. So this is Swires syndrome. Okay. Because the testes doesn't work, there is no androgen in the body. There is, of course, estrogen is also deficient. So the external genitalia doesn't get virilized. The external genitalia is female type. External genitalia is female type in Swires. Okay. So regardless of the karyotype, if there is no androgen in the body, the external genitalia will be female type. Okay. So here, despite having XY karyotype, you all understand my point. Okay. Here, despite having XY karyotype, the external genitalia is female type. Okay. What is TFS? Why is the answer not TFS? Okay. In TFS, again, the karyotype is 46XY. Okay, so TFS is nothing but androgen insensitivity syndrome. Testicular feminization syndrome is called as androgen insensitivity syndrome, where the androgen doesn't work in the body because the receptors are insensitive. Androgen receptors are insensitive, they don't respond. Okay, so here the androgen levels in the body will be normal. Serum testosterone will either be normal or high. Okay, it will be in the male range. Serum testosterone will be in the male range. But that doesn't work. Okay, neither testosterone nor DHT, dihydrotestosterone, works in the external genitalia. And the external genitalia will not get virilized because the receptors are insensitive. So, the external genitalia will be male type or female type. Here again, the external genitalia will be female type. External genitalia will be female type. Okay, so here again, as I told for Swires, here again, the karyotype is 46XY. So, despite having an XY karyotype, the external genitalia is female type. Okay, so this is about Turner's, Swires, and why this is not Turner's, Swires and androgen insensitivity syndrome. Okay, so you all know what is Klinefelter, no? Klinefelter is, what is the karyotype in Klinefelter? Come on, give your answers. The karyotype in Klinefelter is 47XXY. Okay, 47XXY is the karyotype in Klinefelter. Okay, rarely it can be 48XXY or it can be a mosaic type also. Okay, mosaic type with 46XY and 47XXY. Okay, so what are the clinical features here? Short stature, decreased bone mineral density, gynecomastia, short penis, lack of insight, poor judgment and poor attention. Okay, so these are the clinical features. Okay, short stature, decreased bone mineral density, gynecomastia, short penis, lack of insight, poor judgment and decreased attention. And of course, this patient also has some late sequelae. This guy is at risk of certain malignancies. Okay, so he is at risk of breast cancer, he is at risk of mediastinal germ cell tumors. Okay, he is at risk for breast cancer and mediastinal germ cell tumors. Apart from these, he is also at risk for varicose veins, leg ulcers and pulmonary disease. Okay, varicose veins, leg ulcers and pulmonary disease. Yes, SLE and diabetes. So, these are certain conditions which he is at risk of for. Okay, so this is about Klinefelter syndrome. Okay, so moving on, the next question here is about tamoxifen. Patient with breast cancer treatment with tamoxifen presents with complaints of bleeding per vagina. What is the most likely cause? Okay, before coming to the answer, let me tell you what is tamoxifen. Okay, its indications, contraindications and the side effects. Okay, tamoxifen is a SERM. What is SERM? Tamoxifen is a SERM. SERM is selective estrogen receptor modulator. Okay, SERM is selective estrogen receptor modulator. That is SERM. Okay, so what does that mean? It has agonistic properties in certain tissues and antagonistic properties in certain other tissues for estrogen receptors. Okay, so this drug tamoxifen works as an estrogen antagonist in the breast. Okay, you all know estrogen is responsible for breast cancer, right? There is one type of breast cancer which solely depends on estrogen and progesterone for its growth. Okay, so estrogen receptor antagonist in the breast is a drug that will prevent breast cancer, which is nothing but tamoxifen. Okay, so antagonist in the breast, what does it do to the uterus, to the endometrium, to the bones? It is an agonist in the endometrium. It is an agonist in the endometrium and bones. Okay, so having understood its action in different tissues, the end result is very much obvious, right? So, what does it do to breast cancer? It is used to treat breast cancer. It is used to treat breast cancer, treat as well as prevent. Okay, treat as well as prevent breast cancer, especially in estrogen receptor positive breast cancers. Okay. What are the other benefits? Because it has agonistic activity in the bone, it prevents osteoporosis, because you all know estrogen is good for the bones. Okay, so it prevents osteoporosis, and you all know estrogen increases high density lipids and decreases the bad cholesterol, the LDL cholesterol. Okay, so estrogen prevents dyslipidemia, and that is why men are at risk for thromboembolic events, atheroma formation, and not women. Okay, so estrogen prevents osteoporosis, and estrogen decreases cholesterol levels. It prevents dyslipidemia. Okay, so these are the other benefits. Now coming to the side effects. What does tamoxifen do? Yes, it causes menopause-like symptoms. What are menopause-like symptoms? Hot flushes, yes, night sweats, vaginal dryness, but not osteoporosis. Osteoporosis is one other menopause-like symptom, but in osteoporosis, here because of its differential action, in bones it is an agonist, and in the other parts like blood vessels and all, tamoxifen is an antagonist. So it leads to hot flushes and night sweats, but not osteoporosis. You understand, no? And that is why we call it as, okay, it can increase the risk of DVT and stroke, because estrogen is a prothrombotic hormone. Estrogen is a prothrombotic hormone. Okay, so this increases the risk of DVT and stroke. Okay, this increases the risk of endometrial cancer and cataracts. Why? Because it is an agonist in the endometrium, as I already told you. Okay, so it increases the risk of endometrial cancer. Okay, which is a very important MCQ point. Very important. So you give it for the treatment of breast cancer, the woman ultimately develops what? Endometrial cancer. Okay, next is tamoxifen in pregnancy. Is it a teratogenic drug or a safe drug? What's your opinion? Can a pregnant lady take tamoxifen, or can a lady who's planning to conceive take tamoxifen? What's your answer? Yes, give your answers in the chat box. Yes, is tamoxifen safe during pregnancy? Can a pregnant lady take tamoxifen, or is it a teratogenic drug? Okay, take it from me. Tamoxifen is a teratogenic drug. Tamoxifen is a teratogenic drug. Okay, very important MCQ. Tamoxifen should not be given to pregnant women. Okay, this question was there in the last, I think, NEET PG or INI-CT. This question was there. The question was, how many months prior to conception should tamoxifen be stopped? How many months prior to conception should tamoxifen be stopped? Okay, tamoxifen should ideally be stopped 3 months. 3 months prior to the planned pregnancy. Should tamoxifen be stopped? Okay, so when should tamoxifen be stopped? Stop tamoxifen 3 months prior to the planned pregnancy. Okay, this was the question asked in the last INI-CT exam. When should tamoxifen be stopped in a woman who is planning to conceive? 3 months prior. So if at all the lady takes tamoxifen, what will happen? During pregnancy, what will happen? Tell me. Yes, what are the side effects? What will happen if she takes it during pregnancy? Name one anomaly which tamoxifen causes DES-like abnormalities, diethylstilbestrol-like abnormalities. Okay, so what does that mean? Yes, uterine anomalies. Okay, it can lead to abnormalities of the genital tract like uterine anomalies, T-shaped uterus. T-shaped uterus. It can also increase the risk of endometrial and vaginal cancer. Okay, genital malignancies. It increases the risk of genital malignancies in the baby after it is born. Okay, in utero exposure of tamoxifen increases the risk of genital malignancy in the late adulthood. Okay, so increased risk of genital malignancy. These are the hazards of tamoxifen. So tamoxifen should not be given for a pregnant woman. You all understand? Yes? So this is about tamoxifen. So what is the answer for this question? Pregnant patient with breast cancer treatment with tamoxifen now presents with complaints of bleeding per vaginum. The most likely cause is endometrial cancer. Okay. So, yeah. Moving on, we have an instrument here. Okay, you can all see this instrument. So, in the proximal part, the instrument is cone shaped with spirals. Okay. So, this is cone shaped, and here you have longitudinally running spirals here. And this is designed to fit into the cervix. You can place the instrument on the cervix and you can screw it. Okay, if you screw it, it will easily get into it. Okay, so this is one instrument, and here on the distal side, you have a knob. You have a knob into which a syringe fits, and in the syringe you will have a dye called methylene blue, which is pushed into the uterus. Okay, so this is a device which is designed to fit into the cervix, through which you will push a dye, either methylene blue or any radio opaque dye. If you push methylene blue, you can see whether the methylene blue is coming into the uterus and through the fallopian tubes into the peritoneal cavity with a laparoscope. Or if you push a radio opaque dye, you can take X-ray. Okay, you can take X-ray and you can see the radio opaque dye filling into the uterus. So let's say this is the uterine cavity. Okay, so this is the tube. Okay, so what will you do? You will fit the instrument like this, the cone shaped instrument like this, and when you push dye, the dye is supposed to fill the uterine cavity and through the fallopian tubes is supposed to spill into the peritoneal cavity, and if you take X-ray, the whole thing will be visible. Okay, so this test is called as hysterosalpingography. Okay, so this instrument is used for hysterosalpingography. What is the name of this cannula? That is the next question. Come on, give your answer. What is the name of this cannula? Name the cannula. Yes, what is the name of this cannula? Okay, let me tell you. This cannula is called as Leach-Wilkinson cannula. Okay, this cannula is called as Leach-Wilkinson cannula. Very important MCQ. Leach-Wilkinson cannula. Okay. So next is, what is the ideal day to perform this test? Give your answers. What is the ideal day to perform this test? Come on, give your answers. When should this test be performed? On which day of the menstrual cycle should this test be performed? Yes, the ideal day to perform this test is day 7 of the menstrual cycle. Okay, not in the luteal phase, because there are chances for the lady to be pregnant in the luteal phase. There are chances for a fertilized egg to be there in the fallopian tube in the luteal phase, and it shouldn't get flushed into the peritoneal cavity by performing a hysterosalpingography. So it's ideal to perform this test in the follicular phase, in the first half of the menstrual cycle, ideally after cessation of menses. Okay, like if you perform it during menses, all the menstrual blood will spill back into the peritoneal cavity, which is called as retrograde menstruation, which itself is a risk factor for endometriosis. Okay, so you shouldn't do it when the lady is still bleeding. You should only do it after she has stopped bleeding, which is roughly day 7 of the menstrual cycle. Okay, what is the dye used here? If you're going to see it with a laparoscope, then what we use is methylene blue. What we use is methylene blue for laparoscopic chromoperturbation. Okay, the dye used for laparoscopic chromoperturbation is methylene blue, but the dye used for hysterosalpingography, okay, the same instrument is used for both laparoscopy and hysterosalpingography. If it is hysterosalpingography, then it is an iodine-based dye, okay, then it is an iodine-based radio-opaque dye, iodine-based radio-opaque dye. And there are two types, one is water soluble dye and the other one is oil soluble dye, and this is used for HSG, hysterosalpingography. Okay, indications whenever you want to evaluate for infertility, okay, to see whether the tubes are patent, okay, to see the tubal patency, okay. Next is to visualize the uterine cavity whenever you suspect uterine anomalies, okay. Suspected uterine anomalies, okay, or Asherman syndrome, okay. So these are what can be diagnosed, okay. So what all can be diagnosed? As I mentioned here, it can diagnose any problem that is within the uterine cavity, like say Asherman's. What is Asherman's? What is Asherman's? Come on, tell me, what is Asherman's? Intrauterine adhesions, correct. Intrauterine adhesions. Asherman's is intrauterine adhesion. So it can diagnose Asherman's. It can diagnose intracavitary fibroids. Intracavitary, that means submucous fibroid. Intracavitary fibroid means submucous fibroid. Okay, submucous fibroids. Okay, it can diagnose uterine anomalies. It can also diagnose tubal block. Okay, it can also diagnose what? Tubal block. So what all can it diagnose? Asherman's, submucous fibroid, uterine anomalies and tubal block. What are the contraindications for this procedure? The contraindications for this procedure are, yes, name some contraindications. What are the contraindications for this procedure? Very good. Pregnancy is a contraindication. You will definitely not perform this test for a pregnant lady. Pregnancy is a contraindication. Active or current PID is a contraindication. Please remember, treated or resolved pelvic inflammatory disease is not a contraindication. So, if the patient gives history of pelvic inflammatory disease, say 1 year back and 2 year back, and if it has successfully been treated, then that is not a contraindication. Only current PID is a contraindication. Then allergy to the dye is a contraindication. So, obviously, you will not do it for any woman coming with amenorrhea for the fear of pregnancy, right? So, you will make her bleed and only then perform the test, okay? So, these are the contraindications for HSG. Okay, fine. Now, again, there is one more question on HSG. Again, this is an image-based question. You can all see this image. Okay, so here, though the image is not clear, here there is this is the outline of the uterus. Okay, so yeah. Now, listen. Once you take an X-ray, because it's a radio opaque dye, once you take an X-ray, the whole cavity will be white in color. Okay, the entire cavity will be triangular and white in color, fully white. Okay, now in this image, you can see that in the central part of the image, there is filling defect. So, here this triangular portion is black in color, which is called as filling defect, which means dye hasn't entered that particular portion of the uterine cavity. You understand? Dye hasn't entered that particular portion of the uterine cavity. That's filling defect. Okay. So, how are we going to handle this filling defect? Yes. So, you should first of all evaluate and see what it is due to. This filling defect can be what all? This filling defect can be Asherman's. As I already told you, it can be intrauterine adhesion, or this filling defect can be fibroid. Okay. Which type of fibroid? Submucous fibroid. Okay. So, what is it? Here the answer is Asherman syndrome. Asherman syndrome. Okay. So, it's very obvious. Unicornuate uterus and septate uterus are conditions where it is not just a filling defect. Rather, unicornuate uterus is a banana shaped uterus. Here the uterus will be banana shaped, because unicornuate means one horn of the uterus will be missing. Okay. So, instead of being triangular, it will be banana shaped. Banana shaped. Okay. So, this is unicornuate. Okay. How will septate be? In septate, the uterus will have a midline septum. The uterus will have a midline septum here. The cavity will have a midline septum here. So, this area alone will not get filled with dye. The rest of the areas will get filled with dye. Okay. So, what will happen here? This area will get filled with dye and this area will get filled with dye. The center alone, there will be no dye. The center alone, there will be no dye. So, ultimately what will happen when you take X-ray? The center alone will be radiolucent. Okay, the dye filled area will be radio opaque. So, as a result, it will be like this, V-shaped. Okay, it will be like this, V-shaped. Okay, so this is what is seen in septate uterus. Septate. Okay, fine. Moving on to the next question. The next question is on tocolytic. So, listen, the question is, ritodrin to prevent premature labor will cause all of the complications in the mother except. So, the options are bradycardia, hypoglycemia, tremors and pulmonary edema. What is ritodrin first of all? Ritodrin is a tocolytic drug. It is a beta agonist. Okay. What is tocolysis? Tocolysis. Come on, give your answers. What is tocolysis? Toco means uterus. Toco means uterus. What is lysis? Lysis? Abolishing the contractions. You abolish the uterine contractions, that is tocolysis. Okay. Any drug that inhibits the uterine contraction is tocolytic. Okay. So, what are the tocolytics that are commonly used? The tocolytics that are commonly used are beta agonist, magnesium sulfate, NSAIDs, nifedipine and atosiban. 5 drugs. Apart from this, we can also use progesterone as a tocolytic, but progesterone doesn't work much in the second and the third trimester. Progesterone works well in the first and the early second trimester. Okay, so our drugs of interest are beta agonist, magnesium sulfate, NSAID, nifedipine and atosiban, out of which the two beta agonist drugs that are used as tocolytic drugs are what all? Name them. Name the beta agonist drugs that are used as tocolytics. Yes. So we have different beta agonists, no? Salbutamol, terbutaline, ritodrin and isoxaprine. Yes. We use terbutaline as a subcutaneous injection. Okay. When we do procedures like external cephalic version. Okay. Before we do procedures like external cephalic version, we use subcutaneous injection of terbutaline to keep the uterus quiet and silent. Okay. Apart from this, we also use ritodrin and isoxaprine as tocolytic drugs. Okay. Okay. Fine. Listen, ritodrin is the only FDA approved tocolytic drug. Ritodrin is the only FDA approved tocolytic drug. But for this reason, if you ask me, is ritodrin the drug of choice for tocolysis? My answer is no. Ritodrin is not the drug of choice for tocolysis. Why? Because ritodrin has several side effects. Okay, ritodrin has several side effects, and that is why ritodrin is not used as a tocolytic drug. In fact, we do have better tocolytics like calcium channel blockers, for example, nifedipine, which are much safer than ritodrin and are the drugs of choice now. Okay, so ritodrin is not the drug of choice. So why is ritodrin not the drug of choice, and what does ritodrin do? Ritodrin causes hypoglycemia. Okay, and ritodrin increases the fluid retention. Okay, it increases fluid retention. It can lead to pulmonary edema. Okay, it can lead to arrhythmias. Okay, pulmonary edema, arrhythmias, hypoglycemia. Okay, beta agonists decrease the pulmonary edema, arrhythmia and hypoglycemia. So these are the important side effects of ritodrin. They can also lead to tremors. Okay, so here the next drug is magnesium sulfate. Okay, magnesium sulfate of course is a tocolytic drug, but more than a tocolytic, this is an anticonvulsant drug. Magnesium sulfate is an anti-seizure drug, and of course it is a tocolytic drug too. Okay, magnesium sulfate again is not commonly used for this purpose because magnesium sulfate is a toxic drug. It has a narrow therapeutic index. Magnesium sulfate has a narrow therapeutic index. Okay, so we don't commonly use magnesium sulfate for tocolytic purpose. Okay, but it has certain advantages that it is a neuroprotective drug. Magnesium sulfate is a neuroprotective drug. Okay, so what does it do? It decreases the risk of cerebral palsy. Okay, it decreases the risk of cerebral palsy in the baby. Okay, so magnesium sulfate, because of its narrow therapeutic index, magnesium sulfate is not commonly used for this indication. But you tell me, in the last INI-CET exam we had a question on toxicity of the magnesium sulfate, and the question was which is the first sign of magnesium sulfate toxicity? What is the answer? Which is the first sign of magnesium sulfate toxicity? Yes, the first sign of magnesium sulfate toxicity is loss of deep tendon reflexes. Okay, the first sign of magnesium sulfate toxicity is loss of deep tendon reflex. Okay, so it is an anti-seizure drug, it's a tocolytic drug, it's a neuroprotective drug. Okay, NSAIDs, most important NSAID which is used here is indomethacin. Okay, so are we using NSAID for tocolytic purpose? Tell me. Give your answers in the chat box. Are we using it for tocolytic purpose? No. Why? It has a very specific complication which is keeping indomethacin away. A unique complication. What does indomethacin do to the baby, to the fetus? First of all, NSAIDs lead to, correct, oligohydramnios. Okay, first of all, NSAIDs lead to oligohydramnios. And the second important point is that NSAIDs lead to premature closure of ductus arteriosus. Premature closure of ductus arteriosus. Okay, oligohydramnios and premature closure of ductus arteriosus, and for this reason, women when put on NSAID during pregnancy should be put on subjected for fetal echo periodically to see whether the ductus arteriosus is patent. Okay, so for this reason, indomethacin or any other NSAID is not commonly used as a tocolytic. Okay, so which drug is the most commonly used tocolytic? Tell me which drug is the most commonly used tocolytic? Most commonly used tocolytic? What is your answer? Correct, nifedipine. Nifedipine is the most commonly used tocolytic. Nifedipine is the most commonly used tocolytic. Okay. Is nifedipine the safest tocolytic? Give your answers. Is nifedipine the safest tocolytic? What do you say? Nifedipine is not the safest tocolytic. We have one more. Yes, that is atosiban. Okay. Atosiban is oxytocin receptor antagonist. What is atosiban? Atosiban is oxytocin receptor antagonist. Okay, and atosiban is the safest tocolytic. Very important MCQ. Which is the safest tocolytic? In fact, the tocolytic of choice in women with heart disease. The tocolytic of choice in women with heart disease. Atosiban is the tocolytic of choice in women with heart disease because that is the safest and more physiological. Okay, so these are the MCQs from tocolytic drugs. Okay, so this is it. Coming to the question, Ritodrin to prevent premature labor will cause all of the complications in the mother except pulmonary edema, tremors and hypoglycemia are known complications of Ritodrin, which is not a complication. Bradycardia is not a complication. Okay. Next question here, what should be the treatment of an 8 cm endometriotic chocolate cyst? Okay. Now you can see that there is a fluid filled structure here. There is a fluid filled. Why do I say fluid filled? This is an ultrasound image, no? Why do I say fluid filled? What is the usual color of a fluid filled structure in ultrasound? What is the usual color of a fluid filled structure in ultrasound? Black. Black. So the echogenicity is described as what? Echogenicity is described as anechoic. Anechoic. Okay, fluid filled, black or anechoic. Okay, fine. So this is a cyst, definitely a cyst involving the ovary. Okay, so what are the different types of cysts seen in the ovary? Cysts can be functional cysts. Functional cysts. They can be endometriotic cyst, which is otherwise called as chocolate cyst, and they can be tumors. Tumors can be benign tumors or malignant tumors. Tumors can be benign tumors or malignant tumors. These are the differences. Okay. Now remember, out of these, functional cyst is usually a simple cyst. Okay. Functional cyst is usually a simple cyst, whereas chocolate cyst and tumors are usually complex cyst. Okay. Functional cyst is a simple cyst and the other cysts are complex cysts. Okay. So, what are the differences between the functional cyst and other complex cysts, let's say endometriotic cyst? What's the main difference between a functional cyst and an endometriotic cyst? Please remember, functional cysts usually measure less than 5 cm, usually around 4 cm, whereas endometriotic cysts usually measure more than 4 cm. Okay, they are quite big. Okay, and this regresses with menses. In functional cysts, usually functional cysts appear in women with regular menstrual cycles and it spontaneously regresses and it almost disappears on day 2 of the next cycle. Okay, whereas this grows with every menstrual cycle. The endometriotic cyst, because it's nothing but collection of menstrual blood, right? So with every menstrual cycle, there is more and more collection of menstrual blood and there is a growth of the cyst. So this grows with every menstrual cycle. So here it is clear and homogeneously black. Okay, it doesn't have any internal echoes, it doesn't have any solid particles, so it is usually clear. It's a clear fluid because of which it is uniformly black. Whereas here there will be internal echoes, sometimes there can be solid components, like usually an endometriotic cyst will have clots inside, right? So there can be solid components. Okay, so in ultrasound, amidst the black background, you will have white dots or white substances floating here and there. Okay, so this is internal echoes. Okay, and this is a well capsulated cyst. Endometriotic cyst is a well capsulated. So is it a true capsule or a false capsule? What do you say? Endometriosis. In endometriosis, what do you have? True capsule or a false capsule? In fibroids, fibroid is covered by a true capsule or a false capsule? Yes, fibroid is covered by a false capsule. False capsule. Whereas chocolate cyst has a true capsule. You all understand? Fibroid has a false capsule. Chocolate cyst has a true capsule. Okay. So how are we going to manage endometriotic cyst? Yes. See, if it is an asymptomatic cyst and the lady is a postmenopausal lady, you can wait and observe. Just follow the patient. Okay, if it is an asymptomatic cyst and a postmenopausal lady, you wait. For symptomatic cysts, definitely we'll have to treat. For symptomatic cysts, we're going to treat. And here there are two options. One is medical management and the other one is surgical management. Okay, medical and surgical management. Now the question is on surgical management because the size is what? 8 centimeter. Okay, so what is the cutoff for surgical management? Whenever the cyst measures more than 4 centimeter and whenever the cyst is not responding to medical treatment, you will go for surgical management, which is nothing but cystectomy. The surgical management of choice here is cystectomy. Cystectomy. Okay, fine. So for all other patients, if the cyst is less than 4 centimeter, you will first try medical management. That is what you have to understand. If the cyst measures less than 4 centimeter, okay, for any cyst measuring less than 4 centimeter, you will try medical management. But if it's more than 4 centimeter or if it is not responding to medical management, then you will move to what? Surgical management. Okay, so this is it. So the question is what? 8 centimeter endometriotic chocolate cyst, which is quite big and is definitely a criteria for cystectomy. Okay, so the answer is cystectomy. Okay, so what should be the treatment of an 8 centimeter endometriotic chocolate cyst? Now, needle aspiration, definitely no. GnRH agonist, definitely, because of its size, if it's 4 centimeter or less, then I would even go for GnRH agonist because here it is 8 centimeter. Definitely the treatment of choice is not GnRH agonist. Conservative since asymptomatic, I am right now not going for this because you see endometriotic cyst usually doesn't shrink. They don't shrink. Okay, endometriotic cyst will grow with every menstrual cycle. So when will I consider waiting, thinking that it will shrink by itself? Only if the patient has stopped bleeding, no? Or else every time the patient bleeds, the cyst is going to grow a little. Okay, so only for postmenopausal lady will you wait and just observe without intervening. Rather, for all premenopausal women, whoever is menstruating, you will definitely have to intervene regardless of the size, and either you have to give medical management or surgical management depending on the size of the lesion. So definitely here the answer is cystectomy. Moving on to the next question. Question number 11 is here. According to the recent updates of MTP Act in 2021, a registered medical practitioner can terminate the pregnancy up to how many weeks? Okay, so you all know that the MTP Act got revised recently, because of which we are expecting questions from MTP Act. Okay, so it got revised very recently. So I'll tell you all the points that can be asked in the recent MTP Act. Okay. So, you all know the definition for abortion, right? Abortion is the termination of pregnancy before the period of viability. Okay. So, according to the WHO cutoff for viability is 500 gram or 20 weeks of pregnancy. That is the WHO cutoff, which is more likely to be asked in the exam. Okay. So the WHO cutoff says that the fetus becomes viable after 20 weeks, and after weighing 500 gram. Okay. So when was the MTP Act passed? The MTP Act was passed in 1971. MTP Act was passed in 1971, and new MTP Amendment Bill was introduced very recently in the year 2020, April 2020. Okay. So tell me, according to the new bill, according to the old bill, you tell me MTP can be done up to how many weeks? According to the old bill, MTP can be done up to how many weeks? Yes, MTP can be done up to 20 weeks according to the old bill, but according to the new bill, it can be done up to 24 weeks. You all understand? Okay, 20 weeks and 24 weeks. Okay. So, according to the old bill, opinion from one doctor was enough. Okay. Up to 12 weeks, one doctor's opinion is enough. That means one gynecologist can opine that this is a valid indication for MTP. You understand? So, if the pregnancy is more than 12 weeks, between 12 and 20 weeks, two gynecologists should opine that yes, this is a valid indication for MTP. Okay. So, one doctor and two doctors for less than 12 weeks and more than 12 weeks. But here, according to the new amendment bill, up to 20 weeks, one doctor's opinion is enough, but between 20 and 24 weeks, because here now MTP can be done up to 24 weeks, right? So, between 20 and 24 weeks, two gynecologists' opinion should be obtained regarding the indication for MTP. Okay. And also remember, if there is a lethal anomaly, like say anencephaly, yes, which is not compatible with life at all. Anencephaly is not at all compatible with life. And in such cases, if there is a major anomaly or a lethal anomaly, and MTP can be done at any gestational age, regardless of the trimester, MTP can be done. Okay. And regarding the consent, more than or equal to 18 years, the woman herself can consent, and if she is less than 18 years, the guardian has to consent. And husband's consent, what do you say, guys? Is husband's consent required for an MTP to be performed? What do you say? Husband's consent is not required. Okay, the husband's consent is not required for an MTP, performing an MTP. Okay. Regarding the persons qualified to perform MTP, any postgraduate degree in OB&G like DJU, or a master degree in OB&G or a DNB degree in OB&G, any postgraduate degree in OB&G is eligible to perform an MTP, or a registered medical practitioner with 6 months training in OB&G, or a registered medical practitioner who has assisted 25 cases of MTP with 5 MTPs done as a primary surgeon. Okay, so if you are an MBBS doctor, you can still perform an MTP. You understand? So you need you don't require a master degree or a diploma degree in OB&G. If you are an MBBS doctor, you can still perform an MTP, provided you assist 25 cases with me. And out of these 25 cases, you have to be the primary surgeon in 5 cases under my guidance. And this has to be done under my guidance, and at the end, I'll give you a certificate that you have to that you have completed the training, and then you become eligible. Okay, so this is one, or else you'll have to do a 6 months internship in OB&G. Okay, so what are the indications? Contraceptive failure, rape, physical or mental abnormalities in the fetus rendering the fetus severely handicapped, and risk to the life or grave injury to the physical or mental health of the woman. These are the indications for MTP. Okay, fine. Next is about techniques. Okay, so we have medical techniques. We also have surgical techniques. First of all, we divide this into first trimester MTP and second trimester MTP. Okay, under first trimester MTP, we have medical surgical. Again, under second trimester, we have medical surgical, but second trimester is preferably done by medical methods, because in second trimester, the fetus will be well grown, and if you use a surgical technique like suction evacuation, you will have to remove the fetus in piecemeal, which should be better avoided, and medical method would be the best option in second trimester MTP. Okay, so what are the methods for first trimester MTP? The methods for first trimester MTP are medical and surgical. Under medical, we have 3 drugs. Okay, we have 3 drugs. What are the drugs? Can someone name the drugs? Yes, can you name the drugs? What are the 3 drugs used for medical abortion in the first trimester? Yes, we have mifepristone, we have misoprostol, we also have methotrexate. Okay, mifepristone, misoprostol and methotrexate. Okay. Now the next question is, up to what gestational age can we perform a medical abortion in the first trimester using mifepristone and misoprostol? Yes, up to what gestational age can we perform a medical abortion using mifepristone and misoprostol? Yes? Yes, it is 9 weeks or 63 days. Okay, up to 9 weeks or 63 days you can perform a medical abortion using mifepristone and misoprostol. Okay. So, tell me, what is the most common regimen adopted? In fact, we had one question from regimen adopted, no? In the last FMGE exam, I guess, last but one FMGE exam, we had one question on the regimen. Okay. So, basically what I'm asking is how much of mifepristone to give, how much of misoprostol to give, and in what interval. What is the dose of mifepristone? Tell me. What is the dose of mifepristone? Yes, the dose of mifepristone is 200 milligram. Dose of mifepristone is 200 milligram. Very important MCQ. Okay. So, how much of misoprostol will you give and after how many hours of mifepristone? That again is a very important MCQ. Yes, misoprostol is 800 microgram, preferably per vaginal. You can also give it per oral, but preferably per vaginal. Okay. So, 200 milligram of mifepristone followed by 800 microgram of misoprostol 48 hours later. So, the time gap is 48 hours. Each and every word is an MCQ here because they've been continuously asking questions on medical termination of pregnancy. So, the techniques are important. Again, the doses are important. At what intervals you will give, that again is important. Okay. So, 200 milligram of mifepristone followed by 800 microgram of misoprostol per vaginally in a gap of 48 hours. This is the most commonly adopted medical technique. If not this technique, then you can also use methotrexate as a sole drug for first trimester miscarriages. Okay. And here the dose is 50 milligram per meter square intramuscular. Okay. So, tell me, how will you give methotrexate? What is the route? Yes, intramuscular, 50 milligram per meter square intramuscular, or you can also use this regime which is 1 milligram per kg body weight. Methotrexate IM injection of 1 milligram per kg body weight. Okay. So, methotrexate can either be followed by misoprostol or methotrexate can be used alone. Okay. But mifepristone cannot be used alone. Okay. Please remember, if required, methotrexate can be used alone, but mifepristone cannot be used alone. Okay. So, these are the regime, first trimester medical regimes. Okay. Mifepristone, misoprostol and methotrexate. Okay. 3M. Okay. So, what are the surgical techniques available here? The surgical techniques are manual vacuum aspiration, dilatation and evacuation and suction evacuation. Okay. Manual vacuum aspiration, MVA. What is that MVA? Manual vacuum aspiration. See, here in manual vacuum aspiration, we have a syringe like this. Okay. This is the MVA syringe. Okay. This is the MVA syringe, manual vacuum aspiration syringe. Okay. So, by the side of this, you can see some cannula, right? You can see cannula in different colors. Yes. What is this cannula called as? Can anyone give the correct answer? What is this cannula called as? This cannula is called as? Yes, Carman's cannula. Okay. So, this is MVA syringe and this is Carman's cannula. Okay. What do? We attach the Carman's cannula to this MVA syringe, to the tip of this syringe, and we introduce this into the uterus. And we pull the syringe to suck the contents out. This is what we do. But there are certain other MCQs that you have to remember. What are they? Point number 1 is, up to how many weeks can this MVA syringe be used? Give me your answers. Up to how many weeks can this MVA syringe be used for MTP? Yes, MVA syringe can be used up to 12 weeks of pregnancy. Okay, very important MCQ. MVA syringe can be used up to 12 weeks of pregnancy. Okay, next question is, what is the capacity of this MVA syringe? The capacity of this MVA syringe is 60 ml. Okay, it's a 60 ml syringe. The capacity of the MVA syringe is 60 ml. Okay, And next is, does it require general anesthesia or regional anesthesia? No, it only requires local anesthesia, which is a paracervical block. Okay, so it requires a regional block, which is paracervical block. Okay, and the last question is, what is the pressure created? Pressure created with this syringe. How many of you know the answer? Give your answers. What is the pressure created with this MVA syringe? Yes, the pressure created with this MVA syringe is 660 millimeters of mercury. Okay, so 660 is the pressure created with this MVA syringe. Okay, so what are the points under MVA syringe? The first point is identification. Image will be given and you will be asked to identify the syringe. That's point number 1. Second is Carman's cannula. Image of Carman's cannula will be given and you will be asked to identify that. Third is up to how many weeks? 12 weeks. Fourth is the capacity, 60 ml. And fifth is anesthesia under paracervical block. And the next is the pressure created, 660. Okay. What is likely to be asked next? Okay. Examiner can ask about the size of the Carman's cannula. Okay, in fact, we already had one question on the size of the Carman's cannula. She will specify one particular gestational age and she will ask you what size of Carman's cannula you will use. Okay, and let's say you are handling 10 weeks pregnancy. Come on, tell me what is the size of the Carman's cannula used for a 10-week pregnancy? Yes? Give your answers. What is the size of the Carman's cannula used for a 10 weeks pregnancy? Correct. Okay, it is 10 mm. Okay, so size of the Carman's cannula in millimeter corresponds to the period of pregnancy in weeks. You understand? So if it's 8 weeks pregnancy, it should be 8 mm cannula. Okay, if it's 10 weeks pregnancy, it should be 10 mm cannula. Okay, so size of the Carman's cannula in millimeter corresponds to the period of pregnancy in weeks. Okay, fine. Also, I will show you few more instruments related to medical termination of pregnancy, which are likely to be asked in the upcoming FMGE exam. See, what instrument is this? See this, all of you. What instrument is this? This is ovum forceps. Okay, this instrument is ovum forceps. Very important MCQ, ovum forceps. Now, how do you differentiate this instrument from other instruments? What are the unique features of this instrument? See, in this ovum forceps, you will not have a lock. You understand? Okay, in this ovum forceps, you will not have a lock. Whereas in a sponge holding forceps or a vulculum or a tenaculum, you will usually have what? Lock. Okay, even in an artery forceps or a Babcock forceps or an Alice forceps, all other forceps that we use in gynecological surgeries, we usually have lock. Okay, so here in ovum forceps, in fact, this is the only forceps where we don't have a lock. Okay, ovum forceps doesn't have a lock. And see the tip of this forceps. The tip of this forceps is like a spoon shaped. Okay, you can see here. Okay, so there is no lock and the tip is spoon shaped. So what is this? This is ovum forceps. What do we use this forceps for? The ovum forceps is used to evacuate the uterus. Okay, ovum forceps is used to evacuate the uterus. Okay, so to remove the products of conception, basically to remove the bits of placenta, we use this ovum forceps. Okay, so this is used as a part of dilatation and evacuation. We dilate the cervix, put in the ovum forceps and evacuate the contents out. Okay, what is this? What you see here is, yes, cervical dilator. Okay, what you see here is cervical dilator, and this dilator is called as Hegar's dilator. Okay, this dilator is called as Hegar's dilator, and here again you have various sizes. You have a thin one, you also have the thickest one. Okay, so this is Hegar's dilator. What do we use it for? We use it to dilate the cervix. Okay, the advantage is that the ends are blunt. They are not sharp. The ends are blunt. So even if you forcibly insert it into the uterus, it will not perforate the uterus. But if you do it with a uterine sound or with any other instrument which is sharp, you are likely to perforate the uterus, right? So the advantage is that it has thin blunt ends. Okay, so this is Hegar's dilator. You can also see the next image. Okay, see this image. As I already told you, this is a plastic cannula. The Carman's cannula is a plastic cannula. I also told you how to select the appropriate cannula. the size of the cannula for that particular gestation. Okay, now listen, you also have cannula that are available in metal, okay, like how you have the plastic cannula, the suction cannula, you also have a metal suction cannula, and that is what you're seeing here. Okay, this is the metal suction cannula, which is very similar to a plastic Carman's cannula, except for the fact that here also you have size options, like how you have in Carman's, here also you have size options. Okay, so except for the fact that this is rigid and it will not yield that much, whereas a plastic cannula will be very yielding and you can little negotiate and go inside. Plastic cannula will not injure the genital tract much, whereas if you forcibly insert a metal cannula, you're likely to injure the fundus of the uterus. Okay, so this is the difference. Okay, now also see this image, tell me what is this? Yes, we had a question on this image too in the last but one FMGE exam. So we had 3 or 4 questions from MTP. We had we had images of uterine curate. We had a question on size of the Carman's cannula. We also had a question on the weeks up to which MTP can be done. And the technique also, we had a question on the dose of mifepristone. So we had 4 questions altogether from MTP alone. Okay, now see this instrument and tell me what is this? Yes, this is a uterine curate, correct. This is a uterine curate, okay. So what do we use it for? This uterine curate is used to evacuate the uterus, like how I showed you the ovum forceps, right? After taking out the big pieces with the ovum forceps, there will be small pieces inside the uterus which you cannot remove with an ovum forceps. Okay, and some of those pieces might be adherent to the uterine wall, the endometrial wall, for which you will require the curate. Okay, so what you will do is you will scrape the endometrium. Okay, with this curate, you will scrape the superficial layers of the endometrium. So along with the products of conception, some part of the endometrial tissue will also come out. So this is uterine curate. So this curate can be used either for gynec purposes or for obstetric purposes like medical termination of pregnancy. We also use it for taking endometrial biopsy in case of abnormal uterine bleeding. Okay, so here please remember, because we are discussing about MTP, I'm telling you there are 2 ends here. One is a sharp end, small one which is sharp. The other one is a big but a blunt end. Okay, so please remember this big and the blunt end is used for a pregnant uterus. Okay, pregnant uterus. Why? Because to avoid perforation, as you all know. If you use the sharp end, the pregnant uterus will be very soft. If you use the sharp one, you will easily damage the endometrium. You will either perforate the endometrium or you will injure the basal layers of the endometrium, which will lead to scarring inside the endometrium, which is called as Asherman's. Okay, so for pregnant uterus, use a big and a blunt end, and for a non-pregnant uterus, use a sharp and a small end. Okay, so this is about uterine curate. Okay, so this is the suction apparatus which sucks the contents out in case of suction evacuation. Okay, last but not the least, you also tell me what are the signs of complete evacuation. How will you get reassured that you have evacuated all the products? Come on, what are the signs of complete evacuation? That is likely to be asked, no, in the next FMGE exam. Okay, so when will you stop evacuating? When will you stop curating the uterus, or when will you stop suctioning the uterus? What is the clue with which you will make sure that you have completely evacuated the uterus? Tell me 1 or 2. There are 4. You tell me 1 or 2. Yes? Okay. Listen, there are 4 important signs of complete evacuation. Okay. There are 4 important signs of complete evacuation. What are they? Point number 1, the size of the uterus will decrease. Okay. Uterus will shrink. Okay. That's point number 1. Uterus will return not exactly to the pre-pregnant size, but to some extent to the pre-pregnant size. Okay. So that is first point. Second is there will be gripping sensation at the internal os. Why? Because whenever the uterus is empty, os tends to close. Whenever the uterus has something inside, either the product or the menstrual blood or whatever, os will remain open. Now here, once evacuation is complete, what will the os do? Os will tend to close. Okay, and that will be felt as a gripping sensation at the level of internal os. Okay. The next is grating sensation in the endometrium. Okay, when you scrape, you will feel that grating sensation. Okay. The fourth is appearance of fresh blood, which is bright red blood. Okay, usually when there are contents inside, the blood will be dark altered brown in color. Once it is, once the evacuation is complete, when you start scraping the basal layers of the endometrium, it will start bleeding freshly, and that is how you will identify that, okay, this is the limit to stop. Okay, so these are the 4 signs of complete evacuation. Okay, now coming back to the question. So the question is here, according to the recent MTP Act 2021, a registered medical practitioner can terminate pregnancy up to how many weeks? So what is your answer? Yes, what is your answer? According to the present guidelines, MTP can be done up to 24 weeks. Can be done up to 24 weeks. Okay. See the next question. Which of the following is an absolute contraindication for IUCD insertion? Which of the following is an absolute contraindication for IUCD insertion? So I'll tell you before that, if any one of you know the answer, please tell me what is the answer here. Option A is unexplained vaginal bleeding. Option B is history of previous pelvic inflammatory disease. Option C is previous ectopic pregnancy, and option D is HIV positivity. Can anyone give the answer? Okay. Let me tell you the contraindications for IUCD insertion. Okay. See, definitely IUCD should not be inserted for any pregnant woman or woman with amenorrhea wherein you suspect pregnancy. Okay, so amenorrhea and pregnancy are absolute contraindications for IUCD insertion. Next is septic abortion or current PID. Whenever there is active infection inside the uterus, definitely you will not insert. But past history of infection is not a contraindication. Treated or resolved PID is not a contraindication, but current PID or current infection, current sepsis is definitely a contraindication, in fact, a strict contraindication. Unexplained vaginal bleeding is a contraindication because there is a possibility of genital malignancy being there. Genital malignancy and all unexplained vaginal bleeding should be definite contraindications, absolute contraindications for IUCD insertion. And gestational trophoblastic disease. In gestational trophoblastic disease, the uterus will be very soft. So if you insert an IUCD, what will happen? You're likely to perforate. Okay. Combined oral contraceptive is the contraceptive of choice for post-molar evacuation. So here, definitely you should not insert. So these are absolute contraindications for IUCD insertion. There are few other contraindications apart from these contraindications. What are they? They are uterine anomalies. Uterine anomalies, like say septate uterus or bicornuate uterus. Because the uterus, the shape of the cavity is irregular, you're likely to perforate. Either the arms will not open completely, or if the arms open completely, sometimes it can expel or it can perforate. Okay, for this reason, uterine anomaly is a contraindication, but not a strict contraindication. Copper allergy, Wilson's disease, and fibroids, submucous fibroids inside the cavity, okay, are relative contraindications. These are, though not absolute contraindications, it is better to avoid inserting IUCD in these conditions too. Okay. So, this is it. Next is not a contraindication. Which is not a contraindication. I am giving you this list because students usually think that these are contraindications for IUCD insertion. But no, nulliparity is not a contraindication. You all understand? Nulliparity is not a contraindication. Heart disease is not a contraindication. Okay, scarred uterus again is not a contraindication, and HIV positivity you can insert. But the only point is that IUCD is not the contraceptive of choice in a woman with heart disease. You got my point? IUCD is not the contraceptive of choice in women with HIV positivity. In fact, in HIV positivity, condom is the contraceptive of choice. In heart disease, usually the guideline recommends having only one baby for a woman with heart disease, and vasectomy is the contraceptive of choice. I mean, permanent, whenever she wants permanent. Vasectomy, not tubectomy. Vasectomy should be the first answer. If at all she wants a temporary contraception, she's looking forward to get pregnant once again, and she wants to have another baby, and she wants a temporary contraception, then it is good to, put her on IUCD, okay, rather than putting her on COC, because heart disease is an absolute contraindication for COC insertion. Okay, so you cannot give hormones for a woman with heart disease. So you can safely put her on IUCD with, all sterile techniques and antibiotic cover. Okay, so what is the answer for this question? Which of the following is an absolute contraindication for IUCD insertion? The answer is, unexplained vaginal bleeding. Past history of PID is not a contraindication. Past history of ectopic also is not a contraindication. In fact, please remember, copper containing devices do not increase the risk of ectopic pregnancy. They actively prevent intrauterine pregnancy, because of which whenever the lady comes with pregnancy during IUCD, pregnancy with IUCD, it is likely to be an ectopic. Okay, not because of IUCD but naturally. Okay, and again, as I told, HIV positivity is not a contraindication. Okay, so this is it. Moving on, we have the next question here. A female undergoing IVF was given injection HCG for ovulation trigger. Now presents with nausea, vomiting and headache. The USG of pelvis done shows some ascites and the ovary looks like the image shown. What is the most probable diagnosis? Okay, options are serous adenoma, theca lutensis, ovarian hyperstimulation syndrome and PCOS. Okay, now this is a classical history of ovarian hyperstimulation syndrome. She is undergoing IVF and she received injection HCG and she developed ascites after HCG injection and she has multiple cysts in the ovary. Okay, I already told you what is cyst, no? Black anechoic fluid containing spaces are cysts. So, there are multiple cysts in the ovary. Okay, now this is what? This is classical of ovarian hyperstimulation syndrome. This is classical of ovarian hyperstimulation syndrome. Okay. So, you know how the image looks, you know how the history will be. Okay. Now, also you have to know the predisposing factors, the predictors, the severity and prevention. Few points on each of these. Okay. If you know, then yes, any question from OHSs, you can easily manage. It will just be a cakewalk. Okay. So, now you tell me, who is at risk for ovarian hyperstimulation syndrome? Okay. You guys tell me, young woman or old woman? Who is at risk for hyperstimulation syndrome? Come on, give your answers. Who is at risk for hyperstimulation syndrome? Young woman or old woman? Young woman is likely to have a good ovarian reserve and old woman usually has a bad ovarian reserve, right? So, who is at risk? Woman with good reserve or bad reserve? Yes? Woman with good ovarian reserve. Okay. Young woman with good ovarian reserve is at risk of ovarian hyperstimulation syndrome, because more the reserve, more the follicles, no? Yes. So, who will respond to injections more? The woman who has good reserve will grow more eggs and she will increase estradiol dramatically. Okay. So, more increase in estradiol is seen in young women, PCOS women, increased dose of FSH and past history of OHSs are other risk factors. Okay. So, PCOS woman is likely to have an increased ovarian reserve. Okay. These two go hand in hand. Okay. Usually, PCOS woman will have a good ovarian reserve. Okay. And FSH is the key hormone. So, when you give more FSH, more follicles grow. Okay. And they secrete, all of them secrete estradiol. When the follicles grow, what will happen? So, when you give more of FSH, more number of follicles grow. More number of follicles grow. Now, all of them will secrete estradiol. So, E2 levels will increase dramatically. E2 levels will increase dramatically. Okay. So, as a result, what will happen? There is a leak in the vessels. Leak in the vessels, because of which there is, effusion, a collection of fluid in the third space, which leads to effusion. Okay. Pleural effusion, pericardial effusion, ascites. Okay. So, what will happen when there is a intravascular volume depletion? All the fluid all the fluid that are usually present in the inside the vessel will now move out. Okay. What will happen to the intravascular volume? There is a gross decrease in the intravascular volume. There is a decrease in the intravascular volume. Okay. Because of which the blood flow to the kidneys will decrease. What will happen to the urine output? What will happen to the urine output? There is a decrease in urine output. Okay. And depending on the severity of the condition, the patient can either present with oliguria or she can even present with anuria with electrolyte abnormalities. Okay. This is the key pathology in ovarian hyperstimulation syndrome. Okay, so as I told you, ascites will be there, and you can see the question that here also the examiner has given a very nice clue. Ultrasound of the pelvis done shows some ascites. Okay, ascites is there. So these are the risk factors and predictors. Estradiol is, as I already told you, high estradiol is a key component in OHSs. Okay, high estradiol of more than 2500 picogram, increased levels of renin and angiotensin, more than 20 follicles, as you can see here. See, too many follicles, 1, 2, 3, 4, 5, so many follicles, more than 20 follicles seen in ultrasound, and increased blood flow in Doppler. These are the predictors. Okay, high levels of estradiol, more than 2500 picogram, increased levels of renin and angiotensin, more than 20 follicles in ultrasound, seen in ultrasound, and increased blood flow in Doppler. Okay, so fine. What is the criteria to call it critical OHSs? That is the next question. Critical OHSs. Okay, most severe form of OHSs is critical OHSs. When will you call it critical OHSs? If any of these is present, you will call it critical OHSs. Okay, so what's the criteria for critical OHSs? Tense ascites. Tense ascites, large hydrothorax, hematocrit of more than 0.45. Okay, hematocrit is more than 45%. Why is the hematocrit increasing? Because of hemoconcentration, because the fluid, fluid is leaking through the vessel into the third space, because of which the blood is getting concentrated. Okay, so hematocrit of more than 45%, a WBC of more than 25,000, anuria and venous thromboembolism. Okay, anuria and venous thromboembolism. These are the points under critical OHSs. Okay, tense ascites, large hydrothorax, hematocrit of more than 45%, WBC of more than 25,000, anuria and venous thromboembolism. Okay, so how will you treat? Treatment is basically symptomatic. Okay, first of all, you have to avoid pregnancy. The lady shouldn't get pregnant in that cycle. Okay, the lady shouldn't get pregnant until it completely resolves, because with pregnancy, the estradiol levels will further increase and the disease will worsen. Okay, she shouldn't get pregnant. Supportive, all others are supportive measures, like say painkillers. She'll present with abdominal pain, so you have to give painkillers, preferably opioids. And she'll present with vomiting, you have to give antiemetics. You have to give normal saline to increase the intravascular volume, to keep the fluid running inside the vessel so that she produces some urine. Okay, so you have to give calcium gluconate. This is to prevent arrhythmia. Okay, you have to give albumin to combat with fluid loss, and anticoagulants to prevent venous thromboembolism. You all understand? So, treatment is avoid pregnancy, analgesics, antiemetics, fluid replacement by giving normal saline, okay, calcium gluconate, albumin, and anticoagulants. Okay, so moving on to the next question. Here is a question on non-scalpel vasectomy. All of the following regarding non-scalpel vasectomy are correct except. So, vasectomy is the male sterilization surgery, male sterilization technique, right? Vasectomy. Okay, in which we cut the vas deferens. And ligate it. Correct? So, this is vasectomy. Now, vasectomy is a very easy procedure compared to tubectomy, because to get the tubes out, you will have to open the peritoneal cavity. But vasectomy is much easier because the vas deferens lies in the inguinal, canal superficially, wherein all that is required is a very small incision to get the vas deferens out, and it can be done under local anesthesia. Okay, so vasectomy is a simple, technically very simple, easy procedure. It's technically a very simple and easy procedure. Okay, it can be done under local anesthesia. Okay, there is no need for general anesthesia. It can be done under local anesthesia. Next is, yes, it can be done as an OPD procedure. The patient day care procedure. The OPD procedure means day care procedure. Okay, the patient can get the procedure done on the same day and he can go home on the same day. That's, day care procedure. Okay, and yes, there are little hazards. It is of course safe, but the hazards that can be seen with vasectomy are, number one, there can be hematoma formation. Okay, there can be hematoma formation. Number two, there can be a decrease in the sexual drive. There can be a decrease in the sexual drive, but this is not seen with all men, rarely seen. Okay, this is a complication which is rarely seen. Of course, hematoma is also a condition which is rarely seen. Okay, and here decrease in sexual drive again is a rare complication. The next disadvantage is that the guy will not be considered sterile immediately after the procedure. Rather, he has to wait for at least 20 ejaculations or 3 months. 20 ejaculations or 3 months, whichever is later, for him to become completely sterile. Okay, he has to wait for 20 ejaculations or 3 months, whichever is later, for him to be considered completely sterile. Okay, so this is about vasectomy. Let's get back to the question here. All of the following regarding non-scalpel vasectomy are correct except. Point number 1, hematoma in up to 5% of the subjects may occur. This is correct. Sexual function following healing is rarely affected. Yes, it can be affected, but rare, as I already told you. Sterility immediately after vasectomy is wrong. Sterility comes only after 3 months. Recanalization is possible. Yes. Okay, so these are the points under vasectomy. We'll move on to the next question here. The next question is, what is the recommended dose of folic acid in a female with a history of neural tube defect in the last pregnancy? So, what does she have? She has a history of neural tube defect in the last pregnancy. Okay. So, how much of folic acid to give? That's the question. Yeah, this is a very important question. You need to know the dose of folic acid in a normal woman. Okay, prophylactic dose of folic acid. You also need to know the therapeutic dose of folic acid. Okay. Now, here is a table on the WHO recommendation and the Ministry of Health and Family Welfare recommendation on therapeutic doses of iron and folic acid. Okay. So, you tell me what is the recommended dose of iron, prophylactic dose of iron to be given according to the Ministry of Health and Family Welfare. Come on, give your answers in the chat box. Prophylactic dose of folic acid, prophylactic dose of iron. Prophylactic dose of iron, you first tell. Yes? Okay. So, whenever we discuss this question, there is always a confusion between 60 milligram and 100 milligram, and students usually message me and ask me whether to follow 100 milligram or 60 milligram. So, please remember, if you see the word WHO, please stick on to the 60 milligram of ferrous salt. Okay, please stick on to this 50 milligram of ferrous, 60 milligram of ferrous salt starting from the first visit. And this has to be taken for at least 6 months. For at least 6 months during pregnancy and 3 months postpartum. Okay, for at least 6 months pregnancy and 3 months postpartum. This is the WHO recommendation. Next is the Ministry of Health and Family Welfare recommendation. According to this recommendation, Ministry of Health and Family Welfare recommendation, the dose of iron is 100 milligram. Okay, elemental iron is 100 milligram. So, what we have in our government setup, what we have is this 335 milligram of ferrous sulfate tablet, which has 100 milligram of elemental iron in it. Okay, so 100 milligram starting in the second trimester from 14th week. Okay, so there are two recommendations, one by the WHO and one by the Ministry of Health and Family Welfare. The WHO recommends 60 milligram of elemental iron starting from the first trimester. And the Ministry of Health and Family Welfare recommends 100 milligram of elemental iron starting from the 14th week of pregnancy. Okay, and WHO also recommends 400 microgram of folic acid, whereas Ministry of Health and Family Welfare recommends 500 microgram of folic acid. This is the prophylactic dose. 400 and 500 microgram are the prophylactic dose. Okay, so 400 microgram is the same as 0.4 milligram. 400 microgram is the same as 0.4 milligram and 500 microgram is the same as 0.5 milligram. Okay, 0.5 milligram. Okay. So, now the question is on therapeutic dose of folic acid. The question is not on prophylactic dose of folic acid. Now, you tell me what is the therapeutic dose of folic acid? Come on, give your answer in the chat box. Now, we know what the prophylactic dose is, right? Give me the answer. What is the correct answer? Therapeutic dose of folic acid is? Correct, 4 milligram. Okay, therapeutic dose of folic acid is 4 milligram. Okay, What are the indications for therapeutic dose of folic acid? That's the next important question. The indications for therapeutic dose of folic acid are number 1, megaloblastic anemia. Number 2, hemolytic anemia. Okay, hemolytic anemias like sickle cell anemia or thalassemia. Okay, number 3 is over diabetes. Why? Because you know over diabetes is a risk factor for anomalies, fetal anomalies. So over diabetes. The next is anti-epileptic drugs. Women on anti-epileptic drugs like phenytoin, valproate, they are all anti-folate drugs, no? So anti-epileptic drugs. And the next is previous history of neural tube defect, okay, which is the question that we have right now. Okay, so these are the indications for therapeutic dose of folic acid. And how much is the therapeutic dose? 4 milligram is the therapeutic dose. 4 milligram is the therapeutic dose of folic acid. Okay. So getting back to the question, the MCQ that we discussed, it's here. What is the recommended dose of folic acid in a female with a history of neural tube defect in the last pregnancy? The answer is 4 milligram. Okay, very easy question. Okay, moving to the next question. Maximum amniotic fluid is seen at which gestational age? Maximum amniotic fluid is seen at which gestational age? Okay, so here this is a bit tricky because some textbooks say 36 and some other textbooks say 34. But what does Williams say? Williams clearly says that amniotic fluid is maximum at 34 weeks of intrauterine life. I know you will be surprised to know this. Because most of you were of the impression that it is 36 weeks, right? The correct answer is 34 weeks according to Williams' textbook of obstetrics. Okay. So what is the volume of amniotic fluid at 12 weeks of intrauterine life? At 12 weeks of intrauterine life, it is 50 ml. Okay. The volume of amniotic fluid at 12 weeks of intrauterine life is 50 ml. What is it at 34 weeks of intrauterine life? At 34 weeks of intrauterine life, it is 1000 ml and that is the maximum. 1000 ml is the maximum. Okay. So what happens thereafter? The liquor starts decreasing. So what happens to it at 38 weeks? Yes, at 38 weeks, or in other words, I would say at term. Okay, the liquor drops to 800 ml. At term, the liquor drops to 800 ml. Okay, and with further increase in the gestational age, the liquor drops more and more, and by the time the gestational age is 43 weeks, or in any post-dated pregnancy, liquor usually drops to 200 ml. So from this data, you understand that post-dated pregnancy is one important cause for oligohydramnios, right? So what is it at 12 weeks? 5 ml. Okay, 34 weeks, 1 liter. 38 weeks or term, 800 ml. And 43 weeks, 200 ml. Okay, so this is about the volume of amniotic fluid. So the answer is actually 34 weeks. Okay. So next question is here. Which of the following is an indication for surgery in ectopic pregnancy for a woman who is desirous of another pregnancy? Okay. So basically they are asking you the indications for medical treatment or contraindications for medical treatment. Okay. So what is the indication for medical management in ectopic pregnancy? Come on, give your answers. What is the indication for medical management in ectopic pregnancy? Or I'll show you the question. Serum beta HCG less than 1000, absent cardiac activity, ectopic mass of more than 4 cm, unruptured ectopic pregnancy. Tell me, which is an indication for surgery here? Which is an indication for surgery? Yes, ectopic mass of more than 4 cm is an indication for surgery. Okay, so let me tell you the indications for medical management. Okay, prerequisites for medical management. Point number 1. Beta HCG levels should be less than 5000 international units. Okay, beta HCG should be less than 5000 international units. Okay. Point number 2, size of the gestational sac. Size of the gestational sac should preferably be less than 3.5 centimeter. For those of you who are thinking it's 4 centimeter, please note that it is 3.5 and not 4. Okay. Beta HCG less than 5000, size of the gestational sac less than 3.5 centimeter. Okay. Next is absent fetal cardiac activity. Absent fetal cardiac activity. Okay, if fetal cardiac activity is present, it means it's advanced pregnancy, which is not a favorable point for medical management. Okay, so beta HCG less than 5000 international units, size of the gestational sac less than 3.5 centimeter, absent fetal cardiac activity. It should be a tubal ectopic and it should be unruptured ectopic. Okay, tubal and unruptured ectopic. Okay, these are the prerequisites for medical management, and if any of these prerequisites is absent, then you will have to go for surgical management. Okay, so as we already saw the options, beta HCG of less than 1000 can is a favorable point for medical management. Absent cardiac activity again is favorable for medical management. Unruptured ectopic, yes, again is favorable. Okay. So, what is the drug of choice here? Come on guys, tell me, what is the drug of choice for medical management? Yes? Drug of choice for medical management of ectopic pregnancy. What is it? Yes, it is methotrexate. Okay. The drug of choice for medical management of ectopic pregnancy is methotrexate. Okay. The drug of choice for medical management of ectopic pregnancy is methotrexate. Okay. What is the dose of methotrexate? 1 milligram per kg body weight or 50 milligram per meter square. Anything can be followed. Okay. 1 milligram per kg body weight or 50 milligram per meter square, out of which this is much easier. 1 milligram per kg body weight. Okay. IM injection, intramuscular. The route will be intramuscular. Okay. So, also I would like to add on the follow-up after medical management. So, how will you follow the patient after medical management? Tell me. You will follow the patient with HCG, right? To see if it is responding, you will follow the patient with HCG. When all will you take HCG? Tell me, in what all days you will take HCG? Yes? Give your answers in the chat box. Tell me. On what all days will you take HCG? Yes. Day 1, day 4 and day 7. Day 1 is the day you give methotrexate. Okay, day 1 is the day you give methotrexate and you will draw blood again on day 4 and day 7. Okay, now tell me, out of these values, which two value will you compare? Will you compare 1 and 4 or will you compare 4 and 7? What will you compare? You have to ideally compare 4 and 7. Okay, you have to ideally compare 4 and 7, and if there is a 15% fall, if there is a 15% fall in HCG between day 4 value and day 7 value, then it means the drug is working. It's a good response. Okay. If there is no satisfactory fall, if the fall is less than 15% or if it is increasing, what you can do is you can repeat another dose. So, maximum how many doses can you give? Give your answers, come on. Maximum how many doses can you give? How many doses of methotrexate can you give? 2 doses. Okay, you can maximum give 2 doses. So, the next will be day 11 and day 14. So, if there is no satisfactory fall between day 4 and day 7 values, you will repeat methotrexate on day 7. You will repeat methotrexate on day 7 and again you will compare day 11 and day 14. Okay, day 11 and day 14. And again here what you expect is a 15% fall, and if this is there, it is satisfactory, it means the drug is working. If there is no satisfactory fall and if the fall is less than 15%, then that becomes an indication for surgical management, and here you will have to move to surgery, which is nothing but salpingectomy. You got my point? Okay. So, this is about medical management of ectopic pregnancy. Okay. Any questions here? Any questions here? Okay, fine. Now, the next question is on number of prenatal visits? What is the ideal number of prenatal visits? Okay, and there is one word missing here, which is WHO. What is the minimum number of prenatal visits according to the WHO criteria? Okay, now why I am specifically mentioning this WHO? Because WHO has recently modified it. Okay, and that is why the question is there. Okay. So, according to the WHO criteria, the minimum number of antenatal visits or prenatal visits required are 8 visits. Okay, 8 visits. Okay, so how often should the patient come? Listen, visits should be more frequent in the third trimester. Visits can be less frequent in the first and the second trimester. It has, as the gestational age advances, the visits have to be more and more frequent. Okay, so in the first trimester, contact 1 up to 12 weeks. Okay, up to 12 weeks. And in the second trimester, there should be 2 visits, one at 20 weeks and the other at 26 weeks. Okay, so in the first trimester, at least 1 visit. So this number 8 is for minimum number of visits. You understand? So in the first trimester, there has to be minimum 1 visit before 12 weeks or at the most at 12 weeks. Okay. In the second trimester, there has to be 2 visits, one at 20 weeks and the other one at 26 weeks. Okay. In the third trimester, almost every 4 weeks you will have a visit, and especially after 36 weeks, there will be a visit once in every 2 weeks. Okay. So here the first 2 visits will be 4 weekly and then it will be 2 weekly. Okay. So the next visit will be at 30 weeks and then 34, which is 4 weekly. Then it will become, after 34, it will become 2 weekly, which means 36, 38 and 40. Okay. So altogether you have 8 visits, 1 in the first trimester, 2 in the second trimester and the remaining 5 in the third trimester. Okay. So this is about the recent guideline for the WHO guideline for prenatal visits. Okay. Here actually the answer is not there. WHO, when you see the word WHO, the answer should be 8. Okay. So actually the answer is not there. It is 8. Okay. In the exam 8 was there. 8 was there. Okay. Fine. So coming to the next question is on cardiac output. Cardiac output comes to normal after how many days after delivery? Okay. So there are so many questions on cardiac output during pregnancy, during labor and the postpartum period as well. So it's very, very important to know the numerical data related to this question here. Okay. So what happens to cardiac output during pregnancy? First of all, tell me, what is cardiac output? What is cardiac output? Cardiac output is stroke volume into heart rate, right? Cardiac output is stroke volume into heart rate. Okay. Now be ready. Give your answers. Tell me, what happens to stroke volume during pregnancy? Increase or decrease? What happens to stroke volume during pregnancy? Yes? Increase or decrease? Stroke volume increases with pregnancy. Stroke volume increases with pregnancy. Okay. Now coming to heart rate. Give me your answers. What happens to heart rate with pregnancy? Heart rate. Does it increase or decrease with pregnancy? Heart rate increases and so the pulse rate also. Heart rate increases by 10 beats per minute. Okay. Heart rate increases by 10 beats per minute. Okay. So cardiac output, being a product of heart rate and stroke volume, will also increase during pregnancy. So now there are certain questions on certain percentages that you have to remember here. So cardiac output definitely increases during pregnancy. When does it begin to increase? When does it begin to increase? Can you give your answers? When does cardiac output begin to increase during pregnancy? Cardiac output starts increasing as early as 5 weeks of pregnancy. Okay, cardiac output starts increasing as early as 5 weeks of pregnancy. When does it reach its peak during pregnancy? When does it reach its peak during pregnancy? Yes, the answer is actually labor and the postpartum period. Okay, postpartum period. But during pregnancy, it reaches its peak by 32 weeks. During pregnancy, in the antenatal period, the peak is reached by 32 weeks. Okay. So, when does it reach its actual peak? See, cardiac output increases by 40% during pregnancy. Okay, remember these data. Cardiac output increases by 40% during pregnancy and it increases by 50% during labor. It increases by 50% during labor. Cardiac output increases further in the immediate postpartum period. Okay, it increases by 70% in the immediate postpartum period. Okay, cardiac output increases by 70% in the immediate postpartum period. Okay, cardiac output increases by 40% during pregnancy, 50% during labor and by 70% in the immediate postpartum period. Okay, very important MCQ, very important MCQ. Okay, 70% in the immediate postpartum period. So, now our question is what? When does it return to its baseline? It returns to its baseline by 1 week postpartum. Okay, 1 week postpartum is when it returns to the baseline. 1 week postpartum is when the cardiac output returns to the baseline. Here, because 1 week is not there, we can go to the closest option. We can pick the closest option here. Closest answer will be 10 days. Okay, the ideal answer is 1 week. Okay, so this is about return. Okay. So, yeah, next question here, we'll come back to this question, vaginal discharge, but before that, there are some questions which we have already discussed from topics which we have already discussed. A lady with infertility undergoes a laparoscopy for the purpose of assessment of pelvic anatomy for tubal patency. A chromotubation involves pushing dye from a cannula in the cervix which is observed to come out from the fallopian tubes. This chromopertubation is usually done using which of the following? I already told you laparoscopic chromopertubation and HSG. Both of them are done using what? Using methylene blue. Okay, methylene blue. Laparoscopic chromopertubation and HSG are done using, using Leach-Wilkinson's cannula, out of which laparoscopic chromopertubation is done using methylene blue. For HSG, we use a radio opaque dye. Methylene blue is not radio opaque. For HSG, we use another dye which is a radio opaque dye. Okay. We have another question on MTP. Since we've already discussed MTP, I thought I'll finish that. See here, size of the Carmen's cannula at 8 weeks for suction is, give your answers. I've already taught you this. For 8 weeks of pregnancy, what is the size of the Carmen's cannula? Yes? Yes, 8 mm. Okay. So, size of the Carmen's cannula in millimeter corresponds to the period of gestation in weeks. Okay. So, for 8 weeks it is 8 mm. Okay. We also had one more question here from MTP. See this question. Drugs used for medical abortion. Give the correct answer. Since we've already discussed this, give me the correct answer. Which is the drug used for medical abortion? Yes? Correct. Mifepristone 200 mg followed by misoprostol 800 microgram 2 hours later. This is the correct answer. Okay, mifepristone followed by misoprostol. This is the correct answer. Okay. Again, this one I think I taught you. Identify the instrument. What is this? You can see, what is this? You can see an image which has two ends, one sharp end, one blunt end, and this is nothing but uterine curette. Okay, this is nothing but uterine curette. Okay, so let us move on to the other questions. So here we have a question on vaginal discharge. A lady presented with complaints of foul smelling, greyish white discharge and a positive whiff test. On examination, clue cells were seen on microscopic examination. What is the condition and which of the following is the drug of choice for treatment? This is a very easy question and I think you should be knowing, most of you must be knowing what is the correct answer here. The clue is white discharge, greyish white discharge. So, what is the color of the discharge? Color of the discharge is greyish white. Whiff test. whiff test. I'll tell you what whiff test is. Okay, it is positive and clue cells are seen. Okay, the condition is Gardnerella vaginalis. Okay, what is the treatment for Gardnerella vaginalis? The treatment for Gardnerella vaginalis is metronidazole. Metronidazole. Okay. So, what are the differential diagnoses for lower genital infections? Okay, differential diagnosis for abnormal vaginal discharge. Abnormal vaginal discharge. Okay, they are number 1, trichomonas. Trichomonas. Okay, number 2, bacterial vaginosis. Bacterial vaginosis. Number 3, candida. Candida. And number 4, chlamydia. Chlamydia. Okay. Now, please all of you all tell me, trichomonas is caused by a bacteria or a virus or a fungus or a protozoan parasite. What is it due to? Yes? Trichomonas is caused by a protozoan parasite. Trichomonas vaginalis is a protozoan parasite. Okay? What is bacterial vaginosis due to? Come on. What is bacterial vaginosis due to? Bacterial vaginosis is polymicrobial. Polymicrobial. Okay. There are so many bacteria which cause bacterial vaginosis, the most important of which is Gardnerella. Gardnerella vaginalis. Okay, the most important of which is Gardnerella vaginalis. Okay. Candida, come on, give your answers. What is the most common species in Candida? Most common species causing candidal infection? Candida albicans. Candida albicans. And for chlamydia, it is Chlamydia trachomatis. Chlamydia trachomatis. Okay. So, yeah. Next question is the character of the discharge. Okay. Come on, tell me what is the character of the discharge in Trichomonas infection? What is the character of the discharge in Trichomonas infection? Yes? Is it thin discharge or thick discharge in Trichomonas? Thin or thick? Yes, it is a thin discharge. In Trichomonas and bacterial vaginosis, it is thin. In Candida and Chlamydia, you see a thick discharge. Okay. Trichomonas and bacterial vaginosis, you see thin discharge, and in Candida and Chlamydia, yes, thick discharge. Okay. Now, also tell me in Trichomonas, what is the color of the discharge? What is the color of the discharge in Trichomonas? In Trichomonas, it is greenish, frothy. In Trichomonas, it is greenish, frothy. In bacterial vaginosis, it is grayish white or dirty white. Grayish white or dirty white. Okay. In Candida, it is curdy white or creamy white. In Chlamydia, it is purulent, pus-like. Okay. Chlamydial discharge will be like a pus. Okay. Yellowish purulent discharge. Okay. Next is about pH. What is the pH of the vagina in each of these conditions? What is the pH of the vagina in Trichomonas infection? It is more than 4.5. In bacterial vaginosis, again more than 4.5. In Candida and chlamydial infections, it is usually less than 4.5. Okay. Next is about itching. Okay. Which condition is associated with maximum itching? Give your answers. Which condition is associated with maximum itching? Yes. Both Trichomonas and Candida are associated with intense itching. Okay. So, the conditions associated with intense itching are Trichomonas and Candida. Okay. So, Chlamydia, it can either be present or absent, but the condition which is not associated with itching, very important MCQ point. Very important MCQ point. Which condition is associated with no itching? Yes. Yes. Gardnerella vaginalis. Bacterial vaginosis is not associated with itching. Very important MCQ point. Okay. Bacterial vaginosis is not associated with itching. Okay. So, how are we going to diagnose? Diagnosis. Here, it is basically Trichomonas. It is basically clinical diagnosis. We see reddish spots on the vagina and the cervix. What is that called as? Give your answers. Very important MCQ point. Reddish spots on the vagina and the cervix in case of Trichomonas infection is called as strawberry cervix. Strawberry vagina and strawberry cervix. Strawberry vagina and strawberry cervix. Okay. Here in bacterial vaginosis, you have Amsel's criteria. I'll tell you what is Amsel's criteria. Okay. For Candida, you have gram stain, you have KOH mount, you have Sabrot's dextrose agar, and for Chlamydia, you have DNA PCR. Okay, you have DNA PCR. Now coming to Amsel's criteria. What is Amsel's criteria? Amsel's criteria is the diagnostic criteria for bacterial vaginosis. Okay, Amsel's criteria is the diagnostic criteria for bacterial vaginosis, and there are 4 points in it. Okay, what is point number 1? Point number 1 is a vaginal pH of more than 4.5. Vaginal pH of more than 4.5. Point number 2 is grayish white vaginal discharge. Grayish white vaginal discharge. Okay. Point number 3 is the presence of clue cell. The presence of clue cell. Okay. What is clue cell? What is clue cell? Can you give the answer? What is clue cell? Yes, clue cells are bacteria sitting on the surface of vaginal epithelial cell. So, this is the bacteria and this is the vaginal epithelial cell. Okay, clue cells are vaginal epithelial cells with bacteria on its surface. That is clue cell. Okay, 4th point is whiff test. Whiff test. Okay, what is whiff test? Give your answers. What is whiff test? Yes, whiff test is where you have fishy odor. Fishy odor on adding alkali. Fishy odor on adding alkali to the vaginal discharge. Okay, fishy odor on adding alkali to vaginal discharge is whiff test. Whiff test. Okay, so this is Amsel's criteria. pH more than 4.5, grayish white discharge, clue cell and whiff test. So, if any 3 are present, then you will make a diagnosis of bacterial vaginosis. Okay, any 3 out of the 4 will make a diagnosis of bacterial vaginosis. Okay, so this is it about differential diagnosis of lower genital infection or discharge. Okay, so here we have the next question. The next question is on colposcopy. The filter used in colposcopy is, come on guys, what's the filter used here in colposcopy? It is green filter. Okay, the filter used in colposcopy is green filter. Okay, so few more MCQs on colposcopy we'll study. Point number 1, what is this green filter for? What is colposcopy? Colpo means the vagina. Okay. Scopy is to see. Okay. The vagina and the cervix. Scopy is to see. Okay. So, it is an instrument to magnify, okay, and see the cervix basically. Okay. So, what is this green filter for? Tell me, what is this green filter for? Why do we use a green filter there in colposcopy? To see what? To see the abnormal vessels. To see the abnormal vessels. Okay. See the normal vessel, the abnormal vessels which are usually seen in pre-malignant or malignant lesions are a little different from the usual vessels, the normal vessels, in the way that the abnormal vessels can be looped. Okay. It can be looped like this. Okay. Coiled. Or they can be extensively branched, okay, or there can be obtuse angling, okay, like this, okay. So, what are the abnormal vascular patterns? Looping, branching, looping and highly branching patterns are in favor of malignancy, and that is what we see with this green filter in colposcopy, okay. Secondly, what are the indications for colposcopy? That will be the next question here. What are the indications for colposcopy? Okay. Yes, what are the indications for colposcopy? What is the main indication for colposcopy? Tell me one main indication for colposcopy. Yes, abnormal pap smear. Okay, Pap smear is a screening test, right? Whereas colposcopy, with colposcopy, you identify the abnormal site and take a biopsy, which is a diagnostic test, okay? So, point number 1 is, yes, abnormal ectocervical pap. Abnormal ectocervical pap. Because with a colposcope, you can't see the endocervix, okay? With only conization, you can see the endocervix. So, for ectocervix, what you will do is colpo, okay? Abnormal ectocervical pap smear is an indication for colposcopy. Secondly, any woman with symptoms suggestive of cervical cancer. Symptoms suggestive of cervical cancer again is an indication for colposcopy, okay. So, for asymptomatic women, you will take a pap smear, whereas for symptomatic women, you will take a, you will do a colposcopy, okay. Third point, the next point is, whenever the cervix could not be seen with a normal perspeculum, whenever you can't see the cervix for taking a pap smear, you will refer the patient for colposcopy, okay. Whenever cervix could not be visualized, whenever the cervix could not be visualized, the cervix is deep inside to see, is an indication for colposcopy. So, these are the indications for colposcopy: abnormal ectocervical pap, symptoms suggestive of cervical cancer, and whenever the cervix could not be visualized. Okay. Yeah. Next question is here. The next question is on antihypertensive therapy during pregnancy. So, what is the answer here? What is the antihypertensive of choice for a pregnant lady? Yes. What is the antihypertensive of choice for a pregnant lady? The antihypertensive of choice is labetalol. Okay, antihypertensive of choice is labetalol. Okay, why not other drugs? Of course, methyl dopa and hydralazine are drugs that are safe during pregnancy, but still you should not use these drugs during pregnancy. When labetalol is there, whenever labetalol is not there, the second choice would be methyl dopa. I'll tell you why. Okay, first of all, antihypertensive of choice, antihypertensive that can be used during pregnancy. Antihypertensives that can be used during pregnancy are number 1, labetalol, number 2, alpha methyl dopa, number 3, hydralazine, and number 4 is a rare drug called ketanserin. Okay, a drug called ketanserin. Okay, labetalol, alpha methyl dopa, hydralazine, and ketanserin. Okay, what are the drugs that are contraindicated? Any drug other than what is mentioned here is contraindicated. Okay, any drug other than what is mentioned here is contraindicated. Okay, now let me mention some drugs which are strictly contraindicated. They are AC inhibitors, ARBs, diuretics, sodium nitroprusside. Okay. So, these are drugs which are, and of course, non-selective beta blockers. Okay. So, labetalol is indicated despite being a beta blocker only because labetalol is a combined alpha beta blocker. Okay, labetalol is a combined alpha beta blocker. Okay, fine. So, for hypertensive emergencies, okay, for non-severe variety of hypertension, the drug of choice is oral labetalol. And for severe hypertension, it is IV labetalol. Okay, for severe hypertension, the drug of choice during pregnancy is IV labetalol. Okay, so why are we not using AC inhibitors and ARBs? Please tell me, one of you tell me, why are we not using AC inhibitors and ARBs during pregnancy? What's the reason? Yes, they are teratogenic. They cause renal anomalies. Okay, they are teratogenic. They cause renal anomalies and oligohydramnios. Okay, they should not be used. They cross the placenta and go to the fetus. They cause renal anomalies. Diuretics, why? Why shouldn't we use diuretic during pregnancy? Tell me. Because hypertension is a volume depleted state. And diuretics will further deplete the volume. And diuretics will lead to IUGR, intrauterine growth retardation, for which reason diuretics shouldn't be used during pregnancy. Okay, diuretics lead to growth retardation. Sodium nitroprusside will lead to cyanide toxicity in the baby. Fetal liver cannot handle cyanides effectively, so it will lead to cyanide toxicity in the baby. Okay, non-selective beta blockers again can lead to IUGR, growth retardation. So for this reason, these drugs are contraindicated during pregnancy. Okay, but also remember a very, very important MCQ. What is the antihypertensive of choice in the postpartum period? What is the antihypertensive of choice in the postpartum period? Come on, give your answers. I know most of you will be wrong here. What is the antihypertensive of choice in the postpartum period? I'm sure most of you will be wrong. How many of you say labetalol? That's wrong. Labetalol is not the antihypertensive of choice in the postpartum period. Please remember the antihypertensive of choice in the postpartum period is AC inhibitors. AC inhibitors, okay. We avoid using AC inhibitors during pregnancy only for the fear of anomalies. Okay, only for the fear of anomalies. Otherwise, once the baby is already out and once the woman is in the postpartum period, yes, we are free to use any antihypertensive in the postpartum period, and the most effective is obviously AC inhibitor, which is the drug of choice. Okay, let's see the next question. Lady passes urine while coughing or laughing, and what is it? So this is again a very easy question, no? Yes, what is this? This is stress urinary incontinence. This is stress urinary incontinence. So we have urge incontinence, we have urethrovaginal fistula, we have reflex incontinence. Now I'll tell you what these are. Okay. See, urge incontinence is a condition where the bladder gets slowly filled up, and once the bladder is ready for voiding, once the bladder is full, the patient will have a sensation to void, and before she could reach the washroom, she will completely empty the bladder. That is urge incontinence. So urge incontinence is a condition where the bladder slowly gets filled up and the woman has the sensation to void, and when she wants to void, before she could reach the washroom, she will empty it. That's urge. Stress incontinence is where the bladder is not completely full. The bladder is halfway through, and when the woman coughs or sneezes, or when she laughs, okay, whenever she gives a stress, whenever she increases the intra-abdominal pressure, she leaks. That is stress urinary incontinence, okay. Fistula is completely a different entity. Urethrovaginal fistula is where there is a leak of urine inside the vagina. Okay, here in incontinence, it is not inside the vagina, it is outside, okay, outside the urethra, okay. So incontinence and fistula are completely different, okay, fine. So stress incontinence, as I already told you, is where leak coincides with coughing or sneezing or straining, any activity that increases the intra-abdominal pressure. Here, it is unable to control the escape of urine. She is unable to control the escape of urine after the bladder is full. Here, there is no prior urge to void, whereas here, there is prior urge to void. Okay, and usually this stress incontinence, the volume of urine in stress incontinence, the volume of leak is very small. Okay, so this is a small volume leak, whereas this is a large volume leak. In urge incontinence, it is large volume leak. And in both conditions, stress incontinence as well as urge incontinence, the patient is completely aware of it. Okay, and mixed incontinence is a condition where urge and stress both are present. Okay, both during coughing and sneezing and during the sensation to void. Okay, so this I think we finished Carmen's cannula. Yeah, the next question is on serial determination of pregnancy test. Which of the following conditions require a serial determination of pregnancy test? What is your answer? Options are RH incompatibility, molar pregnancy, viability of pregnancy, and gender identification. Okay, so yeah, of course, viability of pregnancy also we do serial determination of HCG, but the most appropriate answer for this question is molar pregnancy, where during the follow-up period, after molar evacuation, during the follow-up period, we usually subject the woman for repeated HCG testing. Okay, so now, why do we subject the woman for a repeated HCG testing after molar evacuation? Yes? Why do we do that? Of course, we do subject the woman for HCG testing. Why? That's because there is a risk of recurrence as well as malignant change. There is a risk of recurrence as well as malignant change with molar pregnancy. You understand my point? Okay. To rule out recurrence and malignancy developing from the previous molar, we subject the woman for HCG follow-up. So, how do we do that follow-up? How do we do that follow-up? That is the most important question. Okay. Remember, we have to first do HCG before evacuation. Okay. First HCG will be done before evacuation and I call it day 0 HCG. Okay. Day 0 HCG. Then after evacuation, you will do weekly HCG. After evacuation, you will do weekly HCG for how long? Until you get 3 consecutive negative weekly values. Okay. So, 3 continuous negative values you will weekly. Okay. So, weekly HCG until 3 consecutive negative weekly values. Okay. Weekly HCG, and then you will do it monthly. Then you will do it monthly for how long? Monthly for 6 months. Monthly for 6 months. Okay. Very important MCQ. So, next question is, when does it usually become negative? Okay, when does it usually become negative? It usually becomes negative by 8 weeks. Okay, it usually becomes negative by 8 weeks. 8 weeks. Important MCQ, 8 weeks. Okay, so follow up, do HCG before evacuation, then weekly until you get 3 weekly negative values, and then monthly for 6 months. Until then, no pregnancy. Okay. So, you have to put her on contraceptive until the, the follow period is over. That means 6 monthly negative values. Okay. So, now again there is a very important MCQ here. What is the ideal contraceptive of choice? Give me your answers. This is a very, very important MCQ. Okay. So, what is the ideal contraceptive of choice? The ideal contraceptive is combined oral contraceptive. Okay, the ideal contraceptive is combined oral contraceptive. Very important MCQ. Combined oral contraceptive. Okay. So, I think this question we've already discussed. Medical abortion. Yes. Yeah. The next question is on Bartholin's gland. Location of the Bartholin's gland. Vestibule, vagina, suburethral and perianal. Where does it open? Where does it open? The Bartholin's gland duct opens in the vestibule. Okay, the Bartholin's gland is very close to the, it is just behind the hymen. Okay, it is very close to the, hymen. Okay, so the secretions usually are emptied in the vestibule. Okay, so fine. What are the other questions from Bartholin's gland? What is it otherwise called as? Tell me. What is Bartholin's gland otherwise called as? What is Bartholin's gland otherwise called as? Bartholin's gland is otherwise called as greater vestibular glands. Okay. Bartholin's gland is otherwise called as greater vestibular glands, and that is why now you understand why vestibule is the answer. Okay. Greater vestibular glands. Okay. What is the size of the gland? The size of the Bartholin's gland? 0.5 to 1 centimeter is the size of the Bartholin's gland. Okay. And the size of the duct is 1.5 to 2 centimeter. Okay. So, gland measures 0.5 to 1 centimeter and the duct measures 1.5 to 2 centimeter. Okay. Where does the duct open? The duct, 2 ducts, one at 5 o'clock position and the other one at, 7 o'clock position. Okay. So, this is 5 o'clock and this is 7 o'clock. So, this is the right duct and this is the left duct. Okay. So, 5 o'clock and 7 o'clock position are the sites where the Bartholin's duct opens. Okay. So, what is the treatment for Bartholin's cyst and what is the treatment for Bartholin's abscess? 2 more questions are there. Okay. So, Bartholin's cyst is a retention cyst. Retention cyst where if the duct gets obstructed, the gland swells. Okay, the gland, it is a retention cyst. Okay, so what is the treatment for Bartholin's cyst? Give your answers. What is the treatment for Bartholin's cyst? Yes? What is the name of that procedure? What's the name of that procedure? Marsupialization. Okay, it is marsupialization. Marsupialization, where you open the cyst, evacuate the contents, and then turn it inside out and suture it. Okay, so that it doesn't accumulate anymore. What is the treatment for Bartholin's abscess? What is the treatment for Bartholin's abscess? The treatment for Bartholin's abscess is IND, incision and drainage. The treatment for Bartholin's cyst is marsupialization, and the treatment for Bartholin's abscess is IND, or incision and drainage. Okay, so this is it. So I think this instrument is done. Okay, so there's another question, which is a very interesting question. A young girl with complaints of not attaining menarche presents with periodic abdominal pain to the hospital. On examination, the following presentation is seen, what is the likely lesion this girl is suffering from. Okay, give your answers, all of you. Come on, give your answers. What is this? Now, the image that you see here is not very clear. Let me show you another image which is much better than this. So, see this, all of you. Can you see a bluish bulging membrane here? Yes. Can you see a bluish bulging membrane here in the vulva? Yes. Bluish bulging membrane. Bluish bulging membrane in the vulva. Okay. What is this condition called as? This condition is called as imperforate hymen. Okay. Imperforate hymen. So, please remember, hymen can remain imperforate even in the neonatal period, but there you won't call it imperforate hymen there, because there what is collecting inside is only mucus, which will appear as yellowish membrane, whereas here after menarche, the post menarcheal woman will present with bluish membrane, because what accumulates inside is the menstrual blood. Okay, so this is nothing but collection of menstrual blood inside. Okay, collection of menstrual blood inside. Okay, fine. So, what are the other features of imperforate hymen? Okay. So, what are the other features of imperforate hymen? Okay. See, in imperforate hymen, you see a bulging bluish membrane at the level of introitus, because the blood collects inside. Okay. So, where all does the blood collect? The blood collects inside the vagina, blood collects inside the cervix, as you can see here. So, this is the uterus, okay, this is the cervix, and this is the vagina, okay. So, what is blood collection inside the vagina called as? Yes, blood collection inside the vagina is called as hematocolpos, okay. Blood collecting inside the uterus and the cervix is called as, hematometra. And blood collecting inside the fallopian tube is called as hematosalpinx. Okay, so blood collecting inside the vagina is hematocolpos, hematometra, which when it collects inside the uterus, and inside the fallopian tube it is hematosalpinx. Okay, altogether this is called as cryptomenorrhea. Okay, so why cryptomenorrhea? Because crypto means hidden and menorrhea means menses. Okay, crypto means hidden and menorrhea means menses. So, hidden menses. The menstrual blood is not able to drain outside because there is a block in the hymen. Okay, the hymen is not open. Okay. So, what will the girl usually present with? The girl will usually present with cyclical abdominal pain or acute pain. Okay. What is this acute pain due to? This acute pain is due to urinary retention or fecal retention. Okay. So, what is the investigation of choice here? Someone tell me, what is the investigation of choice? What is the investigation of choice in case of imperforate hymen? Yes, the investigation of choice and gold standard investigations are different. Okay. Investigation of choice is ultrasound, whereas the gold standard investigation is MRI. Okay. So, there is a difference. So, investigation of choice is a simple investigation which is chosen as the first level investigation, which is nothing but transabdominal ultrasound. Here, because the hymen is blocked, you can't put the vaginal probe inside, and moreover she will be a virgin girl. So vaginal probe shouldn't be put inside. Okay, so here the modality will be trans-abdominal ultrasound, and the gold standard investigation for all cases of imperforate hymen is MRI. Okay, gold standard investigation is MRI. So how will you treat this patient? What is the treatment? Yes, cruciate incision. What is cruciate incision? See, incise the hymen in a cross-shaped manner like how I have done. Okay, so just put an incision like this. This is called as cruciate incision. Okay, so this is the treatment of choice for. So otherwise, how will the secondary sexual characters be for this girl? Tell me. How will the secondary sexual characters be? Yes, will it be normal or abnormal? Secondary sexual character means breast development and pubic hair development. Breast and pubic hair. Normal or abnormal? Yes? Normal. Very good. Normal. Why? Because ovaries are normal here. Ovaries are normal. Okay, the girl will menstruate. Secondary sexual characters will be normal. All serum hormones will be normal. Okay, all serum hormones will be normal here. You all understand? So, this is imperforate hymen. This is imperforate hymen. Okay. So, it was very nice having this discussion with you all. All the best to you all. Prepare well. OBG especially. Concentrate well on OBG because OBG questions are likely to be the most scoring questions because we have 30 questions from OBG, and subject itself is relatively easy compared to medicine and surgery. So, OBG is a high scoring area. Concentrate on OBG whenever possible. All the best to you all. You can reach out to me after the exam for a recall session on FMGE recent paper. All the best.